Good evening, everyone. How are you guys? How are you? Thank you. Oh, yeah, it's very happy to see you guys. Oh my God, it's been long time, right? Yeah, I remember many of the names you people have been attending. Good evening, good evening. Hope I'm audible, everything's clear. So listen to me. Now, so most of you people have one thinking that pharma is very difficult, we might not be able to study. Okay, so we are having confusion. Like there are so many complaints I get on a daily basis, not even sometimes I get this kind of thing. No, it is reality is that many people are scared about pharma, which is not the true statement, which you should never ever say that. Okay, now now listen to me. So, thank you. Now, today we will be doing the rapid revision. So, when we are talking about rapid revision, I'm pretty sure many of you people who are attending right now, you people would be thinking that, sir, we were used to having Hindi and English, but here I'll be doing exclusively in English. Okay, thank you. Now, you can drop your comments in any language. You people know that I can respond to you people. But when we are talking about rapid revision, now most of the students have one saying that what to study, what not to study. In pharma, we'll study this topic, rest we'll leave it. No, that is not the way to do it. You need to study all the topics, but in that you need to catch up the important ones, right? So rapid revision, wherever you are doing, I'll give you one simple basic idea. It should be applicable for all the subjects because you people have a nice good news, right? The exam has been postponed. Yeah, it's really a good news. So utilize that time. Now, without wasting much of our time by giving all these things, definitely you people know where I'll give you insight about everything. So let's start with that, right? And most of you people who are watching me for the first time, good evening everyone. My name is Dr. Maruti. I'm a pharmacology resident at Bangalore Medical College and Research Institute. Now, let's start with one of the most interesting things, that is your autonomic nervous system. The most of the students have, sir, by studying autonomic nervous system, we feel like crying. You don't have to cry. You don't have to at all. Because you need to understand something. Autonomic nervous system, most of us, we end up doing one deadly mistake. The deadly mistake is that we directly go into the drugs. No, that's not a way to do it. When we are talking about autonomic nervous system, let's give a basic idea. So we always have, what is that? That is your sympathetic nervous system. And we have one more nervous system that's called as parasympathetic nervous system. So there are two nervous systems, sympathetic and parasympathetic, which is a self-regulatory nervous system. When we are talking about self-regulatory nervous system, so will it control by itself? Yeah, most of the functions autonomic nervous system, whatever is doing, it is by acting by itself. Now, when we are talking about sympathetic nervous system is also called as, all of you know that is only flight or fight response or a flight or fight nervous system. But I would like to give you people the better idea. Remember it as a thoracolumbar outflow. What do we call it as? Thoracolumbar outflow. What do I mean by thoracolumbar outflow? So thoracolumbar is nothing but all the autonomic nervous system fibers which are related to sympathetic nervous system are coming out from the thoracic and the lumbar vertebra, and they might give you one interesting question, that is where exactly autonomic fibers end. That is your L2, my dear students. What is that? L2 level. So the starting point they will not ask, but they will ask you people about what is that, where it will end. And most of us we are brilliant now, so we tend to go into what, unnecessary things, and we get to confuse. So I don't want my students to do that mistake. I want everyone who is watching to make sure that it ends at a level of L2. When we are talking about parasympathetic nervous system, it is called as craniosacral outflow. It is called as craniosacral outflow. And most of you thinking, sir, you are telling it as a rapid revision, and why are we going this pace? Now just keep watching, you people get into the pace, because we need to get into a sync with each other, right? So sympathetic nervous system, I want you to understand what is the sympathetic effect on the eye. Sympathetic effect on the eye is very simple, my dear students. Sympathetic nervous system will cause mydriasis. And parasympathetic will cause something called as meiosis. What is that? Meiosis. Now most of us will have a confusion, so what is meiosis, what is mydriasis? We always tend to confuse what is that, dilation of pupil and contraction of pupil. Yeah, we studied it very nicely, but at the end, where we made the mistake, where it dilates, where it contracts, and you people end up confusing between these two words. So after today, I don't want my students to have this type of any mistakes. Now listen to me very carefully. That is midrias is nothing but dilation of the pupil. Midrias is nothing but dilation of the pupil. Meiosis is nothing but constriction of the pupil. When we are talking about constriction of the pupil and dilation of the pupil, that is very easy to understand. Thank you so much, sir. Now, listen to me very carefully. Now, dilation is nothing but mydriasis. During mydriasis, how to remember this? We need to go into technique. Technique is very simple. Dilation, pupil is getting bigger. Mydriasis. Meiosis, that is constriction, pupil is getting smaller. How to remember? Sir, look here. Meiosis is nothing but smaller word. The pupil is getting smaller. Mydriasis, pupil is getting bigger and word is also getting bigger. That's it. Now, let's continue. Now, when we are talking about eye, after that, I want you people to understand one of the most important system, that is cardiovascular system. Cardiovascular system. So, cardiovascular system is the place most of the students tend to confuse. It's very simple. Let's imagine you are running. If you are running, what you need? Your body needs more of blood supply, your body needs more of oxygen and all those stuff, right? So for that, how our body will respond? By activating the cardiovascular system. Cardiovascular system, that is sympathetic activity. Sympathetic activity, cardiovascular system, heart rate is the first question. Heart rate will be increased. So I want to tell you people, this concept will be missed out in the physiology. Most of you people who are watching the video, I want you people to make sure and have this concept in your mind. What is that? If the person is having an increased heart rate and CVS having a sympathetic effect, they will ask you one simple thing. On an experimental animal, there we will ask the question, experimental animal, what do they mean? It's very simple. They are talking about animal model. In animal model, they activated a sympathetic nervous system. What will be the effect? That will be your increased heart rate. Increased heart rate and your heart will contract with a greater force. There will be increase of the force of contraction. Heart will contract with a increased force of contraction. And I want you to understand, heart is working more. So heart will require more oxygen. So there will be, heart will have a increased O2 demand. Now, most of the students will have first question, sir, why are you people, everyone who is teaching pharma, why are they focusing on this type of things where it should be covered in physio? Now, the reason is very simple. All the drugs, beta blockers, etc., which we are going to discuss, they will have this effect, increased demand. So to treat that condition, we are going to decrease the demand. For that purpose only, we are going to tell you to learn this. Okay, increased O2 demand. You people understood. So I want you to look here, and parasympathetic, exactly opposite, decreased heart rate, agreed, okay, decreased force of contraction, agreed, okay, decrease of the O2 demand, O2 demand. Now, most of the students, I don't want anybody to be confused, so I want to give you a simple insight and ideology, that is, why are we learning this and how we are going to apply it in pharmacology. Rule number one, I have a patient who is having myocardial infarction. So in which myocardium is necrotized. When myocardium is necrotized, our patient is having an angina in which a demand and supply of the oxygen is impaired. Most of the people will think chest pain is angina. No, chest pain is not called as angina. Angina is nothing but a mismatch between the demand and supply of the oxygen. Now, in this case, the patient is having more demand of the oxygen to the heart and is having a decreased supply. In that time, we can do one thing, increase the supply or decrease the demand. For decreasing the demand, you have two ways to do it. Either activate parasympathetic or inhibit sympathetic nervous system. This thing will be done. Yes, and most of you people, yeah, I'll clear that part as well. That's very simple. What exactly is our target? I'll make sure more than 70% of the question should be solved from you. Yes, this is for FMG Pharma. This is for FMG Pharma. And one more thing, if you are watching for NEET PG, yes, utilize this. Okay. If you are watching for any other exams, watch this. Okay. That is going to help you. That is point number one. Point number two, yes, more than 70% of the question should be solved from you. That is it. Now, let's continue. We learned about the CVS, and most importantly, I want you people to understand gastrointestinal tract. So in the GIT, my dear students, it's very simple. GIT is majorly under the influence of a parasympathetic nervous system, and I quote, remember, it is also under control of enteric nervous system. Yes, if you have questions, type in here and I'll respond. So it is under parasympathetic. Now, GIT, parasympathetic nervous system, the first question they will ask you is motility, Motility, that means peristalsis. Okay. Now another one, that is secretions in the GIT. Secretions in the GIT, and there is one more thing, that is sphincters, that is called as sphincters. So these three things, what happens to each of them, we need to understand. Motility will be increased with the parasympathetic, secretion will be increased with parasympathetic, sphincters will open. Sphincters will open with what? Sphincters will open with the parasympathetic influence. Now, when I'm talking about GAT, the next important concept I want you to understand, sympathetic motility will be decreased, okay, secretion will be decreased, okay, and sphincters will be closed. Sphincters will be closed. Now, if I was an examiner, now, I'll give you an interesting question. This question, let me see how many of you people can answer. So the question is like this. A child who was playing outside came home running. When he came home running, mother advised not to drink water. Is there any scientific reason behind it? Yes, he was running, sphincters are closed, upper esophageal sphincter will be closed, and he will drink water. Water will straight go into trachea. Once it goes into the trachea, aspiration will occur. To avoid that only, we tend to avoid drinking water immediately after running. That is the logic. Got it? Okay. Very good. Aspiration, why it occurs? Why it occurs is the MCQ. The answer is very simple. Upper esophageal sphincter will be closed. Okay, let's continue to the next aspect. That will be your urinary bladder. That will be your, very good, that's it. Urinary bladder, sir, we were confused with the urinary bladder. No need to confuse. Urinary bladder is like a balloon to me. It's like a balloon, okay? And nobody is mocking about my drawing, okay? You're focusing on my explanation. Now, consider this is your bladder. Bladder is having a muscle. What is the muscle? The name of the muscle is the detrusor muscle. And here we have a sphincter. Sphincter is nothing but it is a group of muscles which will close and open. Okay. If at all you are running. Now, I'm going to tell you something, and nobody should take it in a wrong way. On the occasion of International Men's Day, now, my dear students, most of us would have experienced this. When we are in an urge to go for urination, and you don't have availability of the toilet. Okay. Now, I don't want other extra answers here. Now, listen to me. Now, immediately we get a reflex and we start to jump up and down with our own vision. Why that occurs? Because we are trying to activate sympathetic nervous system. When sympathetic nervous system activate, sphincter will close and bladder will relax. Basically, muscle will relax and sphincter will close. That means my patient or me, whoever is in that scenario, will be able to pull the urine for longer period. So during sympathetic activation, muscle will relax and bladder sphincter will contract. So basically, whenever you are under influence of sympathetic nervous system, it is difficult to urinate. Exactly parasympathetic. You're sleeping, you woke up, you need to go to restroom, you went there and you had your urination very comfortably. How that occurred? Because muscle will contract. And sphincter will relax. That is under the influence of your parasympathetic nervous system. That's it. Thank you. So, no, I'm not an ISM graduate. Okay, let's continue. Now, look here. When I'm talking about all these things, relax, contract, etc., done. Now, I want you to understand one important aspect. I kept it for ending. That is your one of the most important. That is salivation. Is that salivation? Okay, sir. What about this salivation? When you are running, salivation will be decreased. That means sympathetic activation, salivation will be decreased, and parasympathetic activation, salivation will be increased. When you are eating food, you are in a rest and digesting mode, so that means you are having, that is, increased salivation. All right. Sir, why are you telling all this? I'll make sure. See, every word I spoke so far, I'll make sure it is interlinked and it's worth it. That's my promise, and I want you people to be focused. Let's continue. Now, when I'm talking about the autonomic nervous system, my dear students, there is one simple thing I want you to understand. Sympathetic nervous system is also called as adrenergic system. Is also called as adrenergic system. Okay, and parasympathetic is called as cholinergic. Called as cholinergic. Now, listen to me very carefully. There is two ways to explain this. One way is that I can put every information on the screen and you people can get confused. The another way is that a small schematic representation solve the problem. So, we are going to go for the second option. Look here. Consider this is your brain. This is your spinal cord. Right? All the parasympathetic fibers are coming either from the cranium or from the sacral plexus. Okay. Now, listen to me. When we are talking about this, we have a cranial nerve coming out, and that cranial nerve is ending. There is a ganglion. After that ganglion, there is a postganglionic fiber, and there will be, what is that? That will be, let's consider blood. Okay. Now, let's take up one sympathetic fiber. And most of the students make one blunder here. So, all the preganglionic, postganglionic finger. This length discrepancy, examiner, if he ever looks into the notes of a FMGE by mistake, he'll make sure to give the question, because the length discrepancy has a different understanding. I'll make sure to clear that. Now, we have a first neuron, it ended, we have a ganglion, we have a second neuron, it is ending into the organ. Okay, let's continue here and look. Here we are having one more fiber, and let's consider it is going to the heart. Okay, if nerve is ending, organ is starting, means there will be synapse. Nerve is ending, next nerve is starting, there will be synapse. Again, same story here, same story here. So in four places, nerve is ending, new nerve is starting. Salivation is not increased in both. Okay, don't get confused. Now look here. So here we need a neurotransmitter. Means from one nerve to the another nerve, if there should be communication. Simple idea. One nerve, another. Communication should be there. Neurotransmitter. Neurotransmitter is required in location 1. Here, organ and neuron. So here also required. Then here also we require neurotransmitter. Here also we require neurotransmitter. So all the places, when we are talking about neurotransmitter, basically whatever nerve fiber which is present, this is the ganglion here. So before ganglion, whatever nerve fiber is there, we call it as a preganglionic fiber. Whatever nerve fiber after the ganglion, we call it as a postganglionic fiber. So I want you to understand neurotransmitters are also can be divided and understood in this way, that is a preganglionic fiber and postganglionic fiber. So what exactly postganglionic and preganglionic fiber? That means during these places, what is the neurotransmitter? We have sympathetic and we have parasympathetic. So in parasympathetic, in both location, of course, all of you know it, just to refresh your memory, that is completely, it is under the influence of acetylcholine. That is why I called it as a cholinergic nervous system. Now, when I'm talking about sympathetic nervous system, preganglionic, we have acetylcholine. And postganglionic, my dear students, here comes a MCQ, but I want you to understand, most important neurotransmitter is noradrenaline. But another neurotransmitter which can be present is adrenaline, and acetylcholine is present in two locations. Acetylcholine is a postganglionic sympathetic neurotransmitter in two locations. Those are sweat glands, my dear. Sweat gland, and one more location is your adrenal medulla. So most of the students remember about the sweat gland. So in the option, they will not give you the sweat gland, rather they will give you about adrenal medulla. So in the adrenal medulla, what you are going to have, that is your acetylcholine, but it is under the influence of sympathetic nervous system, and adrenal medulla will release one neurotransmitter, that is your, very good, adrenal. Let's continue. So wherever I have adrenaline, noradrenaline, I need to have a receptor. What is the receptor? Means is very simple. Here comes the most complicated part of pharma. Take a deep breath and listen to my words. Don't write or do it. Listen, please. It's very simple. If I am going into one room, When I want to open the cupboard, I need to put a proper key. The same way, if I have adrenaline, I need to have adrenoreceptor. Simple logic. Then, when I have acetylcholine, I need to have a cholinergic. Basically, whatever receptor which will be activated by adrenaline, noradrenaline, we are going to call it as adrenoreceptor. Whatever the receptor which will be activated by acetylcholine, we are going to call it as a cholinergic. Now, listen to me very carefully. Very carefully. It's very simple to understand. What exactly is that? I want you to understand the first and most important thing. Cholinereceptors. Oh my God, cholinereceptors. Here comes our problem. We need to remember many locations. When I'm here, you don't have to fear because we'll make it very easy. Cholinereceptors are divided into two types, M cholinereceptor and N cholinereceptor. Your first question, sir, why do we call them as M and why do we call them as N? That is very simple. N receptors will be stimulated by a chemical called as nicotine. When I'm talking about M receptor, they'll be stimulated by a chemical called as muscarine. Now, I want you to understand, being a doctor, we need to have one ideology. What is that? Muscarine is a chemical which can also be found in some poisonous mushrooms. So this is your MCQ 1. What is that? That is your, a patient ingested an unknown mushroom. What poison can occur? Likely to be, it can be a muscarine poison. Now, so why are we talking about this? Because these both receptors can be stimulated by acetylcholine. Both receptors can be stimulated by acetylcholine. So I have both receptors which can be stimulated by acetylcholine, both receptors which can be stimulated by acetylcholine, and at the same time, this M receptor can be stimulated by muscarine, N receptor will be stimulated by nicotine. Let's continue into the next important aspect. So when I'm talking about muscarinic receptors are divided into M1, M2, M3, M4, M5. So I want you to understand one simple concept. What is that concept? So simple rule is that we need to remember the locations of each receptor. That is our major problem. So that problem can be solved by one simple solution. All these 5 subtypes receptors are presented in the central nervous system, which can be found in the central nervous system. But when I'm talking about M1 and M2 receptors, they will have a different locations. And M4 and M5, even they are even interesting. These are exclusively found in the CNS. That means we are left out with 3 receptors. What are the 3 receptors? M1, M2, M3. M1, M2, M3, and apart from M1, M2, M3, my dear students, you are going to have what is that? That will be called as your M4 and M5. They will be present only in the CNS. So we can easily rule out M4 and M5. They are present only and only in the central nervous system. Now, if they are present only and only in the central nervous system, sir, what is that M1? M1 is located, if somebody says to me, if they are located in the stomach, I'll be very disappointed because I want my doctors to be very specific. I want everyone to be telling what is that? They are located in the parietal cell. Now, simple as that. Now, where is your acetylcholine neurotransmitter? It is the neurotransmitter in one location. What is that location? That will be your parasympathetic nervous system. In the parietal cell, M1 receptor. M2 receptors. So, where are they located? In the heart. Okay. Now, M3 receptor, where are they located? It's easy to remember. Other organs means wherever in the body. If parasympathetic is acting, we need what is that? M3 receptor, except for these two. Apart from CNS, CNS will have M1 to M. Okay. Now, N receptor. N receptors are divided into 2 types. NN, NM, NM. 2 receptors. NN receptors are located. Where exactly? They are located in simple location called as autonomic ganglia. Sir, I are familiar with the autonomic ganglia. Those are only ganglions which are present in sympathetic, parasympathetic. Remember, here we had ganglions. Exactly on these ganglions, which receptor you have? NN receptor. NM receptor. They are your autonomic ganglia. They are in the autonomic ganglia. So both, yes, sympathetic and parasympathetic, both of them. Now, NM receptors, very good. NM receptor. NM receptors are present in an interesting location called as neuromuscular junction. And first MCQ, I want you people to remember from path or anywhere, I don't mind, but I want you people to remember these are destroyed. These are destroyed when all of you know one disorder. All of you can answer me interestingly about many things. But destroyed in which disorder? All of you know the disorder name, but people will have a difficulty here with this one particular aspect. What is that particular aspect they will have difficulty? That is very simple to understand. They are destroyed in a condition called as myasthenia gravis. Myasthenia gravis. Autoimmune antibodies, very good doctor. So autoimmune antibodies will be formed as a result of type 2 hypersensitivity. They will be destroyed. Alright. Now we understood about all these things. I want you people to understand one of the most important aspect of what is that. The first important group of autonomic nervous system. I'll go like this only. Even if we take 5 minutes extra, that is not going to lose our time. But rather, if I make it like confusion, you'll be under a great pressure. That's why my dear students. Okay. Now let's start with one of the simple concept that is called as agonist and antagonist. Okay, I'm not going to force you people, but I want an answer. What is agonist? What is antagonist? If I was making a question paper, definitely I would give a question. Definitely. So can anybody tell me what is agonist? And I don't want an answer that is agonist, stimulant, antagonist, blocker. It's not the way to understand. My dear students, you people understood the meaning is correct. But agonist is any drug which will have, I will explain during the general form, but right now I want you to understand these two things. Agonist is anything which can bind with receptor, It can have strong intrinsic activity. Okay, sir, what is intrinsic activity? Now many of my students will have this problem, so let me solve it by doing what? By giving you people one simple idea. What is that? Any drug which will bind to a receptor will do something inside the cell. That's inside activity. Whatever is happening, we are going to call it as a intrinsic. Oh, intrinsic means inside. Yes, of course. Antagonist is any drug which can bind with the receptor, but no intrinsic. No intrinsic. Okay, got it. Let's continue. Now, let's understand one of the easiest group of drugs. The first ones, that the easiest group of drugs is called as cholinergic drugs. Now, cholinergic, which type of cholinergic? Cholinergic, let's start with very easy thing, that is cholinergic. That is nothing but what? If for your confusion, let's clear, they are also called as cholinomimetics. Cholinomimetic. When I'm talking about cholinomimetic, when I'm talking about see, the thing is, I can understand your request, but I need to follow some guidelines, right? I understand that. Okay. Now, cholinergic agonist is any group of drugs which will bind with cholinereceptor, okay, and they will increase the intrinsic activity, positive intrinsic activity. Basic sense is that they stimulate cholinereceptor. If they are stimulating the cholinereceptor, what is going to happen? It's very easy. Cholinereceptors are the receptors which are majorly present in where? They are majorly present in the parasympathetic nervous system. So all the cholinergic agonists, they will activate which nervous system? Parasympathetic nervous system. Now, when I'm talking about parasympathetic nervous system, that means all my drugs, cholinergic agonist, whatever is there, all of these drugs will act upon the cholinereceptor, stimulate the cholinereceptor and activate the parasympathetic. When they're activating the parasympathetic nervous system, now I want you people to remember parasympathetic activation will increase the salivation, will cause the contraction of the pupil. Okay, it will increase the GI secretion, it will increase the GI motility. Okay, all these things I want you to remember. If you understood about it, my dear students, let's start with one of the most important concept in this one only, that is only called as cholinergic neuron. Cholinergic neuron. When I'm talking about a cholinergic neuron, I want you people to understand, look, focus here. So cholinergic neuron, there are hundreds of numerous things, but which I'm going to tell you people in a simplified manner. Let's consider this is a cholinergic neuron. I'm having a postsynaptic membrane. Postsynaptic membrane. Now, when I'm talking about this, basically you have a molecule called as choline. Choline will be taken up into the neuron. Choline will combine with the acetyl-CoA. Acetyl-CoA. Now, will examiner ask about all this? No. He will ask. Basically, acetylcholine is formed. It will go and get stored inside a synaptic vesicle. They are not interested in this also. Whenever I stimulate a neuron, this neuron will allow entry of the calcium ions. Why calcium ion comes inside? I'll explain. I'll make sure to explain the reverse agonist. But we are in a concept. We'll come back to it when we need it, right? But I'll make sure to explain it. Definitely. Now, calcium came inside. This calcium will bombard with the vesicle, will allow a process called as exocytosis. Exocytosis of what? Acetylcholine. Now, I want you to focus here. For the exocytosis, we require a protein called as snare protein. Now, the first thing is that, most importantly, snare protein is there, right? Okay. Now, this snare protein will be inhibited by a toxin. What is the name of the toxin? And if you're telling me the name of the toxin, I'll do the MCQs also, don't worry. I'll give you the MCQs, don't worry. So, if name of the toxin, that is only called as, can anybody tell me? Okay. Even if you don't remember, now we will remember botulinum toxin. Clostridium botulinum. No, tetanus plasmin is different, but Clostridium botulinum inhibits the snare protein, because of which no exocytosis. Write down MCQ number 1. Very good, proud of you. Now, let's understand. Snare protein we are clear, toxin we are clear, acetylcholine. Acetylcholine can act. If I have M receptor, it will act on the M receptor. If I have a N receptor, it will act on the N receptor. Okay. There are other fates which are not important. Now listen to me. Acetylcholine can be metabolized by an enzyme called as acetylcholinesterase. Acetylcholinesterase, usually where it is present. Acetylcholinesterase is the enzyme which is from the postsynaptic membrane, which will break the acetate and which will break it into choline. Choline can be reuptaken, but not always, but many cases it can reuptake the choline, and it can cause, what is that? It can reuptake the choline and it can cause a formation of acetylcholine again. But basically I want you to understand, acetylcholinesterase is a enzyme which will metabolize the acetylcholine into acetate plus choline. Now, when I'm talking about acetylcholine, whichever receptor is there, it will act. Okay. Now, I want you to understand one of the most important aspects is that will be your drugs. So, how to understand drugs? Let's see. All the acetylcholine related drugs, basically those are your cholinergic drugs, can be divided into two types based on their mechanism of action. They can be called as direct acting, they can be called as indirect. My dear students, whenever I say it as a MCQ, I want you people to focus. There will be your MCQ for sure. Now, direct acting drugs and indirect. Direct acting drugs, they're basically what? They bind with the receptor. And they will do what? They will have a positive intrinsic activity. Now, will examiner is interested in all these things? No, we are not writing a theory exam, we are writing a MCQ based exam. So, indirect acting drugs, this will become a very important. So, this mechanism of action is very easy to understand. That is they inhibit acetylcholinesterase. Oh wow, if I inhibit acetylcholinesterase, what will happen? If I inhibit acetylcholinesterase, so acetylcholine will not be metabolized. If acetylcholine is not metabolized, more quantity of acetylcholine. If more quantity of acetylcholine, will have more stimulation of M and N receptor. So what is the MCQ here? These drugs, indirect acting drugs, they are inhibiting what is that? Acetylcholinesterase. That is why we are going to call it as anticholinesterase. Anticholinesterase. So, sir, why are you telling these basics? This basic is the one which will put you in problem on the day of exam. Why it will put you in the problem? The reason is very simple. You'll think about only anti and you'll think it as a cholinoblocker. It is not a cholinoblocker, it is a cholinergic stimulant, basically cholinergic agonist. Why it is agonist? Because acetylcholinesterase inhibition, increase of acetylcholine. If there is an increase of acetylcholine, there will be increased stimulation of the cholinereceptor. Cholinereceptor. The story is over. Very good, physostigmine, neostigmine, but what exactly we need to understand? My dear students, I'm going to simplify this concept for you people. Now, look here, we have a drug called as neostigmine. Okay, we have one more drug called as physostigmine. Okay, neostigmine, physostigmine. When I'm talking about neostigmine and physostigmine, what is the property of this drug? They are basically larger in size. They can be called as quaternary amines, which you need to remember. No, so what you need to know: neostigmine and physostigmine. When we are talking about neostigmine and physostigmine, these are the group of drugs which do not cross the blood-brain barrier. Do not cross the blood-brain barrier. Now, many people have a confusion, sir, when both of them are not crossing the blood-brain barrier. Now, why are we giving each of these drugs in a different way, and why are we preferring one over the other? The reason is physostigmine is a long-acting drug. Since physostigmine is a long-acting drug, this will become your drug of choice for a patient with myasthenia gravis. This will be your first question. So, myasthenia gravis, I'll give you a technique to remember. How many of you are willing to understand myasthenia gravis in few seconds with small techniques? Very easy. Look, myasthenia gravis is an autoimmune disorder in which NM receptors are being destroyed. Basic concept. If NM receptors are being destroyed, if I increase the acetylcholine, there can be increased stimulation of the NM receptor. There were destruction. We are trying to stimulate them. How we are trying to stimulate them? By giving the drugs physostigmine and neostigmine. Got that? Okay. Now, listen to me. It's physostigmine. I'm sorry, it is pyridostigmine. It's pyridostigmine. Okay. Pyridostigmine. Okay. Pyrido. Yeah. Now, listen to me very carefully. Pyridostigmine, when we are talking about this, it is a drug of choice for myasthenia gravis. When we are talking about this, the drug of choice for myasthenia gravis, it is long-acting drug. Basically, it will increase the quantity of acetylcholine, which will improve the patient's symptom. We got the solution. Now, neostigmine can be answered in your question when pyridostigmine is not there. So, let's get to the next one. What is that? We have one more drug, that is your physostigmine. Now, there are uses for physostigmine. Yes, there are many uses, but among which what is important? In a rapid revision, whenever you are studying, I want you to remember one of the most important. It will become an antidote. For what is that? Atropine overdose. Antidote for atropine overdose. Now, don't think that, what we are being confused here. Nothing to be confused. Simple. What is first question? Myasthenia gravis will be drug of choice for myasthenia gravis will have a drug of choice, pyridostigmine. Okay, we'll have antidote for the atropine, that will be your physostigmine. Why physostigmine only? Now, even I am brilliant. I'll ask, why am I using physostigmine as an antidote? Good evening. Why? So that why can be answered with one simple thing. Atropine is a drug which can cross the blood-brain barrier, and physostigmine is also a drug which can cross the blood-brain barrier. This is the concept why we need to remember. Very important. Now let's continue to the next important aspect. What else we have? We have some interesting drugs. What is that? That will be your something called as hydrophonium. So what is this hydrophonium? Everybody is irritating us. Very easy. Hydrophonium is a shortest acting. It is a shortest acting anticholinesterase drug. Hydrophonium widely used for one thing, that is in a condition called as, in a place called as a tensilon test. Is used for a place called as tensilon test. Now, where do we use this test? It is used for myasthenia gravis. Sir, all of us have seen the memes. Go ahead. Now, tensilon test, yes, I agree with you people. Now, what do you use this tensilon test result? Tensilon test result is positive. Tensilon test result is negative. So, what exactly you are going to understand? Tensilon test, if it is positive, tensilon test, if it is positive, that means the diagnosis is myasthenia gravis. All of you know we give hydrophonium to the patient. After giving hydrophonium, if symptoms improve, we call it as positive tensilon test. If positive tensilon test, we diagnose it as a myasthenia gravis. If negative, it should be something else. What can be something else? There is a condition in which presynaptic calcium channels can be destroyed, but that much is not required. So if you diagnose it as a myasthenia gravis, what is the next drug of choice? Again you'll have a MCQ. Again you'll have a MCQ. What is that next drug of choice? Again you'll have a MCQ. The next drug of choice will be your, what is that? That will be your pyridostigmine. So apart from these three drugs, what else we need to remember? My dear students, I want you people to remember, we have a drug called as galantamine. We have a drug called as galantamine. Okay. We have a drug called as rivastigmine. We have a drug called as rivastigmine. Okay. We have a drug called as rivastigmine, galantamine. These drugs can be used in Alzheimer's, but the most important MCQs, what is the drug of choice which is used for Alzheimer disorder? Alzheimer disorder, the drug of choice what we are going to use is, my dear students, the drug which we are using now, that will be your donepezil. What is that? Donepezil. If somebody asks you people, sir, why can't we use rivastigmine? It is having a toxicity. Galantamine is less effective compared to the donepezil. The best drug we can answer is donepezil will be the best drug. All right. Once we understood about this, there is one more summary I am going to give you about these drugs. This is just a start. Now, let's continue to the next part. Let's talk about the direct acting drugs. Now, listen to me very carefully. If I were preparing for theoretical exam of pharma, the direct acting scenario is different. If I'm preparing for MCQ based exam, I want you people to understand what is that direct acting drugs. We have drug called as pilocarpine. My dear students, pilocarpine can be used in a condition called as glaucoma. But do we use it? If I were giving the treatment, no. Why? Because if you do the wrong dosing of the pilocarpine, it can cause one dangerous side effect. Can anybody tell me? What is a side effect which can occur? Okay, I'm looking for your comments. Yeah. So the dangerous side effect it can cause is your retinal detachment. Once retinal detachment occurs, patient can go blind. So I want you to understand, see, visual impairment, accommodation related problems, all those I agree. But major side effect, dangerous one, if you mismatch the dose, this is the answer. Okay. See, why am I telling you people? Because accommodation spasms, all those things can be reversed once. What is the drug effect is gone, but retinal detachment. That's right. Blood vision, minor side. Let's continue. Now, direct acting drugs. Remember one technique. There are most of the drugs, they're acting on one group of receptor. M receptor. Oh, that is why. So, sir, first time I was thinking, Pilocarpine, cholinergic drug. Why can't we use it for myasthenia gravis? The problem is destruction of the NM receptor. Key point. Then direct acting drugs. Why can't we use them for myasthenia gravis? The reason is their major activities on the NM receptor. Now let's continue to the next important drug. What exactly we have? We have a drug. What is that? That is only called as carbachol. What is that? Carbachol. Okay. We have one more drug that is your bethanacol. That is your bethanacol. What is your bethanacol? Now, sir, what is it about carbachol and bethanacol? We need to remember. You need to remember one simple thing. Carbachol and bethanacol, they're activating parasympathetic system. If it is activating parasympathetic system, they will increase. They will increase. What is that? They will increase the activity of the GAT. So we can use in one condition that is only called as post-operative ileus. Trust me, how many of you people genuinely think for yourself? Most of you people remembered ileus and biheaded ileus. Very simple. During the surgery, we would have given multiple drugs, anesthetics, etc., etc. Now, what is going to happen? The patient will have intestinal obstruction or decreased motility of the GAT. We are going to call it as intestinal obstruction is called as ileus. To treat that condition, we need to increase the parasympathetic. We use bethanacol. Nobody will ask you for all this explanation, but to understand that's important. Bethanacol is also used for post-operative. What is that? Urinary retention. Sir, what is this post-operative urinary retention? Same thing. If patient is having urinary retention, activate parasympathetic nervous system, bladder will contract and he will restore the bladder activity. For that, the best drug which we are using is bethanacol. Okay, we have one more drug, that is carb. Okay, so what else we need to know here? I want you people to understand one more thing. What is that? What is that? Listen to me very carefully. That's very simple. You have a drug called as cevimeline. Now, sir, what exactly about cevimeline? Remember about the cevimeline, it is the drug of choice for the treatment of dryness in the mouth caused by a syndrome called as Sjogren's syndrome. Okay, Sjogren's syndrome. Now let me see how much you have prepared and how much you people are in sync. If you are not in sync, you people are having a lot of time which we can solve it. Sir, what is the biopsy finding? Examiner is bored of asking dry mouth, dry eye, dry vagina. So he'll ask, what is the biopsy finding in this patient? He'll give you a 38-year-old female came to the hospital with the complaints of dryness in the mouth. And she was also having a burning sensation in the eye. And she was having pain during the coitus. Doctor suspected a connective tissue disorder. What can be found in the biopsy of the glands? The finding is very simple. See, this is the problem where we are going to get stuck, guys. Sjogren's syndrome is an autoimmune disorder in which destruction of the gland will be there. If there is a destruction of the gland, now what, your gland will keep quiet? No. Your immune system will keep quiet? No. Your gland is being destroyed. Your immune system will try to heal, end up forming. What is that? Connective tissue. Connective tissue. Now, this MCQ was asked earlier times, but nobody have attention also towards this MCQ. Now, apart from that, there will be definitely WBC infiltration. Majority we are going to get which cells? Lymphocytes. Very good. Very good. See, the end summary of sialoadenitis is your connective tissue. Okay, let's continue to the next concept. What exactly I want you people to understand? We have one more drug called as methacholine. Sir, what is this methacholine story? The methacholine story is very easy, my dear students. Methacholine is not widely used in clinical practice, but rather it is not even widely used in clinical practice, rather it is widely used for MCQ making purpose. What is that MCQ making purpose? Methacholine is used in a test called as methacholine challenge test. Methacholine, where exactly it is used? For which disorder? For a disorder called as bronchial asthma. What is that? Bronchial asthma. For bronchial asthma, we are going to use a test that is only called as methacholine. Very good, proud of you guys. Let's continue to the next important aspect. What exactly is that? I'm going to write some conditions. If you don't know anything, you need to remember these drugs which are cholinergic agonists, which can be used for what exactly purposes. The purpose is Alzheimer disorder. Okay, then we are going to use it for Sjogren's syndrome. Sjogren's syndrome. Okay, where else we can use it? We are going to use it for example, what is that? That is a post-operative urinary retention and ileus, post-operative urinary retention ileus. These drugs can be considered in glaucoma, but in today's time we are having better drugs. We start the glaucoma patient usually with beta blockers. Now, apart from glaucoma, where else we can use these drugs? Apart from glaucoma, we can use these drugs in one more place, that is myasthenia gravis. Apart from myasthenia gravis, where else we can use these drugs? We can use it for tensilon test. We can use it for tensilon test. Apart from the tensilon test, we can use them for methacholine challenge test in bronchial asthma. These are the basic concepts which you need to remember, because today's time, the most of the MCQs will be clinical oriented. They will explain you about this disorder and ask the question. So, post-operative ileus comes under as a paralytic ileus. Same thing. So once we understood about this, I'll give you a quick rundown of all the important points related to this group of drugs. First thing, myasthenia gravis. The drug of choice is pyridostigmine. Story is over. Then, how do we diagnose? We have one of the test is a tensilon test, are also called as edrophonium test. And another thing, where else we can use? Cevimeline is used for Sjogren's syndrome. In glaucoma, we can consider pilocarpine. In post-operative or paralytic ileus and urinary retention, we can use this Alzheimer disorder. Donepezil is the drug of. Thank you. But we are done with this concept. Let's go to the next important. What is that? That will be your cholinoblockers. Most of the students are scared about the cholinoblock. There is no way to be scared. Cholinoblockers are also called as cholinergic antagonists. Cholinergic antagonist. Now, what exactly they are going to do? They will block the cholinereceptors. They will block the cholinereceptor. This is a simplified way of saying it, but only blocking. No, we are going to call it as no intrinsic activity. Now, all these cholinoblockers, I want you to understand one of the simplified things. What is that? Let's go organ by organ. Earlier, what we did wide range. Now what we are going to do, let's start with one of the most important thing, that is the central nervous system. Central nervous system, which receptors are? M1, M2, M3, M4, M5. Okay, in central nervous system, what are the drugs we have? Reversibility. See, reversibility is nothing but very simplified idea. Now, reversible is nothing but I have some random receptor, X receptor. I have a drug which will come and bind. Once if a receptor come and bind with that drug, that is going to, what is going to happen? This receptor will be permanently blocked. If I am talking about, that will be called as irreversible. Okay? That means if you need to have the action of this receptor, your body has to synthesize the new receptor. Basically, most of the receptors are protein, so your body has to synthesize the new protein. But reversible, the story is simple. This will come and bind here. It will bind for how long? It will bind for as long as duration of action. Means what? I have a drug which acts for 2 hours. If it is acting for 2 hours, the receptor will be blocked. The receptor will be blocked. That will be blocked only for 2 hours. After that receptor is active, it's active. That means the story of your reversibility and irreversibility. You can apply it anywhere throughout your biochemistry. And if anything, if it is coming back to life, reversible. If it is going permanently, irreversible. Story. Now, in central nervous system, M1, M2, M3, M4, M5. Okay. Among all these things, in the central nervous system, we have one of the widely used drugs are hyoscine. Okay. Now, apart from the hyoscine, I want you to understand this hyoscine is a drug. Iosine is a drug which can also be called as scopolamine. Okay, sir, I feel like we have some association here. Yes, iosine or scopolamine is a cholino blocker which can be acting in the central nervous system. The first question is patch form. It comes under a patch form. Okay, it can also be used in forensic psychiatry. Forensic psychiatry. What is this forensic psychiatry? Forensic psychiatry is nothing but narco analysis. Now, patch form is what? We are going to call it as a transdermal patch. These transdermal patches we are going to apply for a condition called as motion sickness. Okay. Sir, what is there? You are highlighting this too much. Examiner already knows you are under a great stress. He'll play with you. How will you play? A person was going for traveling in a hilly region, and he was supposed to take a scopolamine patch. When he is supposed to apply the patch means after he start to get vomiting he need to apply the patch, or at the start of the travel when he starting to travel, that time he need to apply the patch. That is the first important thing, my dear students. It should be applied approximately at the start of the journey, or prior to the start of the journey. We are going to use these motion sickness patches. Now, we have one more important aspect in the central nervous system. We have one drug called as benztropine. Okay, we have. See, I can understand that. But we need to understand about others also here. That is why. Okay, we'll get used to it. Don't worry. Benztropine, we have a drug called as benzoxol. Okay, sir, why are you telling all these drugs? Simple as that. These are the drugs used for drug-induced Parkinsonism. The first thing, they will not give you what is your drug of choice for drug-induced Parkinsonism. Google can answer that question. Okay, so don't do that mistake. First important aspect, what you need to do. When will we get the drug-induced Parkinsonism? Drug-induced Parkinsonism can be seen with the antipsychotic drugs majorly. Okay, yes, we have other drugs, but I want you to remember these things, especially benztropine. Benztropine has been asked in multiple times next. Now, drug-induced Parkinson, which drugs we are going to use? Drug-induced Parkinsonism, we are going to use. What are those drugs? They are drug-induced Parkinson. They are caused by antipsychotics. They can be treated by these drugs. Let's continue to the next important aspect. What exactly I want you to do? Let's get into the eye. Oh my God. Sir, what about eye? Eye is very simple. In eye, we have parasympathetic nervous system. If I stimulate parasympathetic nervous system, pupil will contract. That is called as miosis. Okay. Apart from that, if I block the parasympathetic nervous system, it will cause mydriasis. Sir, you are telling about only one line, but there is other things also, right? Yes, I'll tell you about that. Just listen. Now, mydriasis. If mydriasis occurs, I can cause the mydriasis and I can use it for what exactly purpose? That is for fundoscopy. So what is fundoscopy? Fundoscopy is your retinoscopy, my dear students. Okay, so mydriasis. So what exactly is happening? Mydriasis occurs, along with that there will be something called as cycloplasia. Now what about this cycloplasia? Cycloplasia is anything in which ciliary muscles are being paralyzed. Now I want you to understand. In the eye, cholinoblockers are used for fundoscopy. What are the drugs we have? Drugs are homatropine. Okay, homatropine. Apart from that, what else we have? Cyclopentolate. Okay, apart from cyclopentolate, we can use one more drug, that is atropine. Now apart from that, what else we have? We have one more drug called as tropicamide. I'm doing some technique here. What is the technique? I'm writing tropicamide and atropine in one location. The reason is very simple. Atropine is used in the children. Why we are going to use them in the children? Because in the children, ciliary muscles are very strong. That is why we are going to use atropine in the children. Okay, tropicamide will be used for whom? Tropicamide is used in adults. Because in the adult, ciliary muscles are not strong as children, so we'll need the action for short period, we can do it. But in atropine we are using in children. The only reason is that children's ciliary muscles are very strong, so we will need to use the most potent drug. One time I'm telling atropine, if that comes again, that will have a importance here. Okay, now apart from the eye, let's get into the next concept. Now this question has been asked. A 2-year-old child, okay, let's make 1-year-old child was brought to the ophthalmic hospital for fundoscopy due to some genetic condition. During this fundoscopy, which drug can be preferred? The drug which can be preferred are these ones. Okay, now what is that next important question? The next important question they will ask you is very simple thing. What is that simple thing? They will ask midriasis with cycloplasia or without cycloplasia. Midriasis with cycloplasia is caused by these drugs. Okay, green is very dull. Okay, let's make it dark, no problem, don't worry. Let's continue. Now let's continue to the next concept. What is that next concept? Let's discuss about, okay, let's go to GIT. In the GIT we have two places. One of them is your parietal cell, okay, and another one is your other locations of the GIT. Other locations, we have a drug called as we have a receptor called as M3. In the parietal cell we have a receptor called as M1 receptor. If I stimulate M1 receptor, it will increase the acid production. Okay, if I block M1 receptor, it will decrease the acid production. So what are the M1 blocker? M1 blocker, we have a drug called as gastrinzapine. Okay, apart from the gastrinzapine, we have one more drug, that is tilenzapine. What is that? Tilenzapine. Now examiner will ask these drugs also, we have better drugs than gastrinzapine and tilenzapine. Okay, but the major problem is my dear students, that will be your, so gastrinzapine is there, and pyranzapine is there. Now these two drugs are, we have better drugs than this, but examiner will ask you which cholino blocker can be used for peptic ulcers. We can use is gastrinzapine and tilenzapine. That's it. Let's go to the M3 receptor blocker. We have a drug called as dicyclomine. Now many of the students will have an interesting thing about dicyclomine, that dicyclomine is also called as what? We can use it, we are going to use it under a brand name we have called as buscopan. Now where exactly we are going to use this? We are going to use it in the spastic abdominal pain. Okay, apart from that, we can use it in the renal colic, but effective for spastic abdominal. Simple. Spastic abdominal pain, smooth muscles in the intestine are going into contraction, because of which pain is being started. That is the basic concept of a colic. Now, if I block this M3 receptor, automatically smooth muscle would relax and pain can be reduced. Okay, let's continue to the next important. What else we have? We have next important place. I want you to understand what is that urinary bladder. Urinary bladder, we have M3 receptors. Okay, now M3 receptors, if I stimulate M3 receptor, bladder will contract and patient will urinate. Simple concept. Okay, if I block this, what is going to happen? Bladder will relax and patient will have decrease of the urination. When do we need to decrease the urination? We are going to use it in one condition called as hyperactive bladder. So we are going to use it where? Hyperactive bladder. When we are having a hyperactive bladder, what are the drugs? We are going to use M3 blockers. Okay, M3 blockers. M3 blockers are what exactly? We will come to the glycopyrrolate. Glycopyrrolate, we are going to use it in a little different usage. We have one important thing, that is only called as oxybutynin. Okay, apart from oxybutynin, what else we have? We have dorifenacin. Okay, we have one more drug called as solifenacin. Okay, then we have one more drug called as trospium. All these drugs where we are going to use, we are going to use them for the hyperactive defect. Now, is there any single best answer in this condition? No. So they cannot give you all the drugs and ask you to choose. Yes, that's what I'm doing. Don't worry. Okay. So trospium we have told already, agreed. But all these drugs, they will give only one drug and ask you the question. Okay. It can be answered very easily. Okay. Hyperactive bladder, we did it. What else we are left? We are left with one of the most interesting location. Bronchus. Okay, sir, what is this bronchus? My dear students, bronchus has M3 receptor. If I stimulate, it will cause bronchoconstriction. Apart from the bronchoconstriction, patient will also have one more thing, increased secretions. Okay, if I block it, the patient will have bronchodilation and patient will have a decreased secretion. Wow. Okay. So what are the drugs we have? Where we can use? We can use them in COPD. We can use them in bronchial asthma. Okay. If we can use them in the COPD and bronchial asthma, what are the drugs we have? Okay, come on, tell me. So we have a drug called as ipratropium. Okay, and we have one more drug called as thiotropium. Now, if I am getting a question, so which is the answer which I need to mark? Simple. So if I give you both options, mark type. Why thiotropium, sir? Long acting. Sorry, over. Okay, we have one more drug called as actinium, agreed, but the two important drugs which are widely available for the practice are thiotropium and ipratropium. Let's continue to the next part. What is that? The most important, the question of heart, sir, that is the M3 receptor, cholinergic action on the heart. We have which receptor? M2 receptor. If I stimulate M2 receptor, what will happen? The patient will have decrease of the heart rate. Okay. If I'm talking about M3 receptor, M3 receptor, that is going to do what? That is going to act upon GIT, eyes, etc. If I block M2 receptor, the patient will have increase of the heart rate. So where can I use it? It can be used in bradycardia. I have a patient who is having bradycardia already. How can I treat it? I can treat it with one simple way. We can, what is that? We can block the M2 receptor. So M2 receptor, the drugs which are used are atropine. The drugs which are used on the heart is atropine. If I have a patient who is having what is that condition? Bradycardia. The first drug I'm going to give is atropine. But the examiner is even more interested in one more condition. Where else we can use atropine? Where else we can use atropine? See, I want you to focus. Very good. They're used in AV block. Why do we use it? Now listen to me. If I ask you what is the best treatment available for a patient with AV block, the best treatment available is cardiac catheterization and treating the person. Okay. But cardiac catheterization and how will I treat? I'll put an artificial pacemaker. If I ask you what is the best drug I have, then I'm going to use which drug? That will be atropine. Yes, OP poisoning, can I use it? See, you can use it. My dear students, mirabagrone is a drug which acts upon the beta-3 receptors and it is used for the bladder. Okay, it is not a drug which is acting on the cholinereceptors. Now, where can I use atropine? In the heart. These are the two conditions. Now, listen to me very carefully. When I'm telling you people atropine, I'm talking exclusively about heart. Atropine other uses. Yeah, we have in OP poisoning. Yes, we can use them. Got it? Okay. Now we are done with all the important aspects of the cholinoblockers on the organs. Cholinoblockers on the organs. So once we understood about the cholinoblockers on the organs, now my dear students, OP poisoning, how we are going to deal? How we are going to deal? We are going to deal OP poisoning in a separate section. I want to teach you people OP poisoning and snake bite separate, because this is having a high tendency patients in India, and we need to have a very clear idea about these things. Okay, so I'll teach you people, but in a different section. Now, with this much being said, I'm pretty confident that you people are having what is that? Having proper communication with me, and you people are able to follow my language, my style, etc. And with this much being said, let's take a break. Let's take a break of how long? Let's take a break of around 10 minutes. Let's take a break of 10 minutes and we will be back and we will be continuing. Don't think I'm giving break, okay? Many of the students are used to this. Sir, whenever he's teaching, once he comes to an end, that means he'll stop for that day. But not going to happen today. Today will be different. We are having a 10 minutes break and we'll be okay. Thank you so much. And for people who are asking about Hindi we'll have a idea. Okay. But I need to talk with the team. Okay. Now listen to me. Thank you so much. Thank you so much. That's the purpose of rapid revision, and that's why we gave that word remarkable, because that is the sole purpose of rapid. Okay. All right. See you people after 10 minutes. Thank you. Don't stop in the middle. Stay tuned. All right, let's start. So when we are talking about the continuation of our revision program, let's start with our next group of drugs. When we are talking about next group of drugs, what exactly the next group of drugs are? The next group of drugs are, okay guys, we are starting now. Next group of drugs, the next group of drugs we are going to discuss, what are those? They are your adrenergic drugs. Adrenergic drugs. When I'm talking about adrenergic drugs, what exactly we need to understand, what exactly the basics we need to know. Let's start with everything, right? When I'm talking about adrenergic drugs are divided as agonist and antagonist. We all know that. But before going to adrenergic drugs, I want you people to understand one important concept here. What is that? That is your adrenergic neuron. What is that? Adrenergic neuron. Adrenergic neuron is even simplified way to understand it. Now, look here, my dear students. Let's consider this is your presynaptic membrane and this is your postsynaptic membrane. Thank you. Now, we have an amino acid called as tyrosine. Okay. Now, many students get confused with the tyrosine and phenylalanine. My dear students, tyrosine itself is an individual amino acid from which we have this will be converted into something called as adrenaline and your noradrenaline. Most important neurotransmitter will be noradrenaline. Right? This noradrenaline, whenever this neuron is stimulated, it is going to be released into the synaptic cleft. Okay. Now, when it is released into the synaptic cleft, now there are stages how tyrosine will get converted into adrenaline, noradrenaline, and dopamine. So these three are the catecholamines. Now there is an order which already discussed in biochemistry. I'm sure about it. Now, noradrenaline will act upon the adrenoreceptors. What are the adrenoreceptors we have? So when I'm talking about adrenoreceptor, this is the place where most of us tend to have a problem. Hope everything is clear. Now, adrenoreceptors, whenever I'm talking about these are divided into alpha adrenoreceptors and the beta adrenoreceptors. Now, let's study with the alpha adrenoreceptor. Alpha adrenoreceptor, basically they can be further divided into two types, alpha 1 receptor and the alpha 2 receptor. Now, when I'm talking about alpha 1 receptor, where exactly they are located? They are located in one of the most interesting places. One of them is your blood vessel. Whenever I stimulate alpha 1 receptor in the blood vessel, it will cause vasoconstriction. Okay. When I'm talking about the alpha 1 receptor, another location, that is urinary bladder sphincter. See, in the sphincter, alpha 1 is there. Agreed. Okay. In the bladder, that is detrusor muscle, what is there? M3 is there. Okay. Now, urinary bladder sphincter. Whenever I stimulate this alpha 1 receptor in the urinary bladder sphincter, now this alpha 1 receptor stimulation will cause contraction of the sphincter. Okay. Now, in the sphincter, which type of alpha 1 receptors are located? In the urinary bladder sphincter, the receptors which are located alpha 1 only, but in that there are two subtypes. That is your alpha 1A receptor. In the blood vessel, what is there? Alpha 1B receptor. Simple story. In the blood vessel, what is there? Alpha 1B is there. In the sphincter, what is there? Alpha 1 is there. Story is clear. Now, whenever I'm talking about alpha 2 receptor, my dear students, this is an interesting one. Alpha 2 receptor can be further divided into alpha 2A to B. But alpha 2 receptors, they are located in the blood vessel. They are located in the vessels. But most important location, alpha 2 receptors, they are also located in the presynaptic membrane. What is this presynaptic membrane? Let's go back. This is your synapse. In the synapse, okay. After the synapse, whatever we have postsynaptic membrane. Before the synapse, whatever we have presynaptic membrane. So alpha 2 receptors are which type of receptor? Presynaptic receptor. Whenever I'm talking about presynaptic receptor, basically noradrenaline will act upon the postsynaptic receptor as well as the presynaptic receptor. When alpha 2 is activated, it will decrease the release of the noradrenaline. Basically, what exactly is happening here? alpha 2 stimulation in the synaptic membrane, that is presynaptic membrane, will decrease release of the norm. Okay, that's simple. I'm talking about two types of receptor, alpha 1 receptor and alpha 2 receptor. Alpha 1 receptors are located in blood vessel, urinary bladder sphincter. That is your alpha 1b subtype in the blood vessel, alpha 1a subtype in the bladder sphincter. And alpha 2 receptors are located in the blood vessel and presynaptic membrane. Simple story. What is that? Alpha 2 receptor stimulation will again cause vasoconstriction. Vasoconstriction will lead to increase of the BP. All of us know that. Now, let's start with a simplified concept. What is that? That is your alpha agonist is any group of drugs which will stimulate the alpha adrenoreceptor. Alpha agonist. My dear students, listen to me very carefully. We can have alpha 1 agonist, right? We can also have, yeah, it works like a break. Of course. Now, alpha 1 agonist. Alpha 1 agonist, I want you people to remember what exactly are the drugs. They are your oxymetazoline. Okay. We have one more drug. That is your xylometazoline, and we have one more drug here. What exactly is that? That is your very interesting drug. What exactly is that interesting drug? That interesting drug will be your phenylephrine. Get ready, my dear students. We are going to get one more question here about the phenylephrine. It's a very favorite question for the exam. Oxymetazoline, xylometazoline. Nowadays, we are going to use them as a nasal decongestant. How exactly they are working as a nasal decongestant? Is it important? No, it is not important when we are talking about MCQ oriented. But when we are talking about phenylephrine, that is totally a different story. Phenylephrine will stimulate alpha adrenoreceptor. I agree with you people, but what exactly is the importance? The importance about phenylephrine, I want you to know what is that. That will be, my dear students, is very easy to understand. This phenylephrine causes mydriasis. Oh, sir, that means, can I use it in the eye? Of course, that means alpha receptors are located in the eye. Agreed. Mydriasis, but what is the question? There is no cycloplasia. If you people can remember, the drugs choline blockers used to do one problem. What is the name of that problem? The name of the problem was cycloplasia as a side effect. But phenylephrine will not cause cycloplasia, and this is an important MCQ of every exam. Okay, we understood about the phenylephrine. Okay, now phenylephrine, sir, is it only alpha 1 agonist? There is some problem. See, it is a strong alpha 1 agonist with the alpha 2 agonist property. Story over, problem solved. Okay, alpha 2. My dear students, listen to me. Alpha 2 receptors are located in multiple locations such as vasomotor area also. In vasomotor area, the story is different. Alpha 2 stimulation in the CNS will lead to decrease of sympathetic activity, decrease the BP. But when we are talking about this particular aspect, what is that? That will be your blood vessel. The direct action on the blood vessel will be vasoconstriction. Okay. Let's continue to the next aspect. What is that next aspect? The next aspect which I want you to understand is alpha 2 agonist. If it is not from pharma, but pharma oriented question only, will come from obstetrics and gynecology. What question will get? I'll tell you people. Now listen to me. Alpha 2 agonist. So alpha 2, if I stimulate, what will happen? It will decrease the release of the noradrenaline. If there is a decrease of the noradrenaline, what is going to happen? There will be decrease of the sympathetic activity. Why? Because no noradrenaline, there will be decrease of the sympathetic activity. That time, what exactly we are going to understand? If there is a decrease of the sympathetic activity, there will be decrease of the blood pressure. Okay, alpha 2 receptors location, they are located, alpha 2 receptors are located even in the central nervous system. Why I told you people, I'll tell you. Okay, now Listen, we have a drug called as clonidine. We have a drug called as clonidine. Okay. We have one more drug called as alpha methyl dopa. Alpha methyl dopa. These are the two drugs which we have as an alpha 2 agonist. When I'm talking about clonidine can be used in hypertension. Okay, but I want you to understand what is alpha methyl dopa. Alpha methyl dopa is safe in pregnancy. But is it the drug of choice in pregnancy hypertension? No. But is it safe in pregnancy? Yes, it is safe in pregnancy. The drug of choice we have for the pregnancy hypertension. In these days, what we are using is Levitlaw. Very good. Let's continue. Apart from that, what is the next question? If I were to be examiner or anyone to be examiner, they will give you one interesting question. What is that? Clonidine, all of us know one thing. What is that? Yes, it is a drug which can be used in hypertension. So they will not ask you, but it is also used in addiction treatment, my dear students. Why am I telling you about the addiction treatment? Because alpha 2 receptors are located in parts of CNS. When I use them, can help in the treatment of addiction. All right. Okay. Let's go to the next concept. What is that next concept? The next important aspect, we have beta receptors. Okay. So what about this beta receptor? Beta receptors are divided into beta 1, beta 2, beta. As much as our exam is concerned, beta 3, we don't have major parts of the drugs. We have beta 2. Okay, we have beta 1. Yes, beta 3 is located in the fat tissue as well as in the urinary bladder, which have a drug. One drug is the mirabagrone. Apart from that, the rest others, we have beta 1 and beta 2 only. We need to remember beta 1 is located in the heart. Okay, where else it is located? It is also located in the kidney. Where exactly in the kidney? It is located in the JG apparatus. Okay, now when I'm talking about heart, whenever I stimulate beta 1 receptor, beta 1 is a receptor of sympathetic nervous system. So that means in the heart, what are the effects which we are going to get by the stimulation of the beta 1 receptor? It will increase the heart rate. It will increase the force of contraction. It will increase the O2 demand. Okay. Then now listen to me. We'll talk about this. Okay. Now beta 2 receptors. Beta 2 receptors are located in your bronchus. They're located in your blood vessel. Okay. They're also located in the uterus of the female. Whenever I stimulate bronchus, it will cause bronchodilation. Whenever I stimulate blood vessel, it will cause vasodilation. Exactly which receptor? Beta 2. Uterus, what will happen? Uterus will relax. Okay. Now, my dear students, let's start with one of the most easiest drugs. What exactly is that? Beta 1 agonist. Okay. When I'm talking about a beta 1 agonist is such a type of drugs. Whenever I stimulate beta 1 receptors, that will lead to increase of the heart rate. Okay, increase of force of contraction. So where exactly we can use them? Think about a patient who is having acute heart failure. In an acute heart failure, the patient is having a bradycardia, decreased cardiac output, and decreased activity of the myocardium. To increase the activity of the myocardium, we can stimulate the beta 1 receptor. The drug which we can use is dopamine. So exactly what I'm talking about, the acute heart failure, also in the cardiogenic shock. Cardiogenic shock is what type of shock? Simple. Heart is the pump. That pump is not. That means pump is not contracting. That is the time where blood pumping will not be there. The patient will go into cardiogenic shock. So for the cardiogenic shock, we can use, what is that? That will be your that will be your dobutamide. Great. Now I want you to understand the next thing. What is that? Beta 2 agonist. Beta 2 agonist. So what is this beta 2 agonist? Beta 2 agonist can be used in the treatment of bronchial asthma. Treatment of bronchial asthma. Okay. If they blindly ask you what is the drug of choice for bronchial asthma, you blindly answer beta 2 agonist. Okay. Vein. Vein is a blood vessel which bring the blood back to the heart. Let's continue. Okay. Now, don't answer this. Deoxygenated blood. What about pulmonary veins? They'll bring oxygenated blood. Any vessel which is bringing the blood back to the heart is called as vein. Any vessel which is bringing the blood away from the heart is called as artery. Okay. Bronchial asthma. They're also used. Okay. Now, what exactly? They're also used in premature labor, but in today's practice, do we use them in the premature labor? No, we can consider them using. Okay, apart from that, do we have any other uses for the beta 2 agonist? So beta 2 agonists, these are the two major uses. We can also use them in COPD. Okay, let's talk about beta 2 agonists. All the beta 2 agonists are divided into your favorite classification, SABA, LABA. What is that? Short-acting beta 2 agonist. LABA, long-acting beta 2 agonist. I want you people to remember, short-acting, that is your salbutamol. Okay, my dear students, can anybody tell me what is the effect of beta 2 agonist on the asthma and COPD? How can we classify based on beta 2 agonist? Okay, we have what exactly? We have a drug. What is that? That is your salmeterol. Okay, we have formoterol. Okay, we have one more drug, therapeutic. Okay, what else we have? We have one more drug, Ritodrin. Ritodrin, earlier it was developed like it was used for premature labor, but today's time we never use Ritodrin for preterm labor, but Ritodrin's main purpose of usage was this. Very good. Asthma is a reversible condition with beta 2 agonist. COPD is a irreversible condition. Let's continue. Now, when I'm talking about this, my dear students, examiner not interested in knowing all these things. He'll ask you about the side effects of this drug. Whenever you are using a beta 2 agonist, there will be vasodilation. Patient will have a reflex tachycardia. Why reflex tachycardia? Beta 2 receptors are located in the blood vessel, which will cause the vasodilation. Because of the vasodilation, the patient can have what is the decreased BP. For that response, your body will increase the heart rate. Okay, reflex tachycardia will lead to what is that? The palpitations. Will lead to palpitations. Now, apart from reflex tachycardia, what else can be there? The patient can also even sometimes develop headache. Apart from that, the patient can also develop tremors. And please don't get confused. During the patient who is having a hyperkalemia, we can use inhalating beta 2 agonist, but not vice versa. For the treatment of hyperkalemia, we can consider about what is those drugs? They are your beta 2 agonists, but they are not the drug of choice. Okay, confusion clear? Let's continue. We are done with SABA, we are done with LABA. Okay, so once we're done with SABA and LABA, let's get into the next important. So for our exam, what are the important aspects? A patient was given treatment for the attack of asthma. After using the treatment, the patient developed a palpitation, headache, and tremor. These can be caused by which of the given drug? The given drugs would be beta 2 agonists. Okay. Let's continue to the next aspect. What is that? Once we are done with the beta 2 agonist, let's talk about the adrenoblockers. When we are talking about adrenoblockers, what exactly we are talking about? Adrenoblockers are the group of drugs. They work as an antagonist to the adrenoreceptor. So when I'm talking about adrenergic antagonist, I want you people to understand. First group of drugs are alpha and are alpha blockers. When I'm talking about the alpha antagonist, they will block the alpha receptor. So if they're blocking the alpha receptor, alpha 1 receptor, let's talk about the alpha 1 antagonist. When I'm talking about the alpha 1 antagonist, okay, I can have alpha 2 antagonist, means I can have a blocker of alpha 2, but I can have, what is that? They're only called as non-selective. Non-selective means what? They are neither selective to alpha 1 nor selective to alpha 2. They will block both the receptor. If they are blocking alpha 1 also, alpha 2 also. What other drugs we have? The drugs can be divided into two types. What exactly these two drugs? The first group of drugs are called as reversible drugs, reversible antagonist, and we have one more drug called as irreversible. When I'm talking about a reversible blocker, I want you people to remember what is that? That is only called as phentolamine. Okay, what else we have? Phentolamine. Irreversible, we have a drug called as phenoxybenzamine. We have a drug called as phenoxybenzamine. So how to remember this drug? Reversible blocker is a drug which has a smaller name. Irreversible is a drug which has a bigger name. Technique to remember. Okay. Now, when I'm talking about phentolamine, phenoxybenzamine, where exactly we use this drug? These drugs can be used in pheochromocytoma. These drugs can be used in pheochromocytoma. Is pheochromocytoma? Pheochromocytoma is a condition in which patient is having a catecholamine secreting tumor. Adrenaline will be secreted in a large quantity. Now that will become a problem because you'll have a secondary hypertension. For the pheochromocytoma, better preferred drug is phenoxybenzamine. Okay, now pheochromocytoma, best medical management, best combination of the drugs is your phenoxybenzamine. Okay, along with that we need to use the drug that is your propranolol. Okay, when I'm talking about propranolol, I'll tell you why we are going to use it when I'm teaching you people about the propranolol. Okay, now once you understood about this phenoxybenzamine, phentolamine, I want you people to understand the next important condition. We use them in a condition called as tyramine reaction. Tyramine is a compound which is present in cheese, not all the cheese, few types of cheese and a few types of wines. In these two conditions, in these two things, not all the wines but few wines can contain tyramine. Because of this tyramine, now that can lead to tyramine can cause something called as cheese reaction. So cheese reaction, patient will have, tyramine is having an alpha stimulatory property, because of which patient will have elevated blood pressure. To control that, we are going to use phentolamine. Why? So why are we using reverse? Tyramine will be present in your system for a particular time period. During the time period only you need the phentolamine. Later, do we need it? No. That is why we are going to use reversible. Reversible will be short acting or irreversible? Of course, reversible will be short acting. Okay. Now, my dear students, we understood about two major uses. See, there are other things to it, but I want you people to remember this much for your exam. During the exam, you should forget this. Let's continue to the next aspect. So, pheochromocytoma, can anybody tell me what is the investigation we can use? What is the investigation we can use to prove the pheochromocytoma? Now, don't tell me, sir, we will use radiology. Please. Why we can't use radiology? Radiology will not tell you what type of tumor it is. It will tell you where the tumor is located. See, urine sample is collected. In urine sample, I can test for bacteria, I can test for ketone, I can test for other things, I can test for urine cast. What am I going to do? Very good. 24 hours urine metanephrine. That is the thing. And vanil mandelic acid can also be checked, but most importantly, 24-hour urine metanephrine levels should be. Okay, let's continue. What is the next important concept we need to understand? So once we understood about this, my dear students, let's start with one of the most interesting concept, alpha 1 antagonist. Alpha 1 antagonist. Without this question, there can never be a paper. There can never be a paper. So I wanted to understand alpha 1 antagonist. We have alpha 1A block. Alpha 1A block. Whenever I'm telling you people alpha 1A blocker, we have a drug called as a tamsulosin. What is that? Tamsulosin. So this is definite MCQ. How exactly they'll ask? I'll tell you. So tamsulosin. We have one more type, an alpha 1A and also alpha 1B blockers. Alpha 1A and 1B blockers, we have so many other drugs. What are those? We have prazosin. We have prazosin. Okay. Apart from the prazosin, we have terazosin. We have terazosin. Okay. We have one more drug called as alfuzosin. Alfuzosin. Okay. So we have many drugs, among which, sir, what is the importance of alpha 1A blocker? I told you people in the starting of our discussion, alpha 1A receptors are present in the urinary bladder sphincter. So to treat that, to treat one condition called as a treatment of, focus on one word here, symptoms of benign prostatic hyperplasia. Don't get confused. It is not a pathogenetic treatment nor a drug of choice as a treatment. It is exclusively for what is that? It is exclusively for what is the management of the symptoms of the benign prostatic hyperplasia. Okay. Now, alpha 1A plus 1B blocker. Classically MCQ oriented, where do we use them? Any patient with hypertension also having a BPH. All of you know that alpha 1B, if I block, it will cause vasodilation and decrease the BP. So please listen to me. Please listen to me very carefully. We have prazosin, doxazosin, terazosin, alfuzosin. You'll remember everything. But if you remember 10 drugs and we forget tamsulosin, then that will become a very bad sin. So don't do that sin. Don't do that sin of forgetting tamsulosin. Remember that tamsulosin. That's it. Right? Patient with BPH and hypertension. Now, what is that next important question? Next important question is that the patient, the question examiner is interested in side effects of all the alpha block. Side effect of alpha blockers. Sir, what are the side effects of alpha blockers and why is it so important? Every person who is talking about pharma, they're focused on this particular aspect. Why? Because it will develop a side effect called as first dose effect. First dose effect. My dear students, I want you people to remember this word, first dose effect. Now, then if I ask you, what is that effect? That is your postural hypotension. Postural hypotension. Sir, what is this postural hypotension? Means he will take a first dose of the drug. He would have gone and slept. He'll wake up. He'll immediately try to get down from the bed. He changed his position from sleeping to standing, because of which venous return will decrease. If venous return is decreased, patient will have a decrease of BP. We call it as a postural hypotension in a simplified words. Happy? Sure. Now, let's continue. Postural hypotension, that is first dose. Okay. Then other important aspect, these drugs when they use, they can also cause one more thing, that is your retrograde ejaculation. Retrograde ejaculation. Right. Let's continue. The next aspect. What is our next important aspect? The next important aspect is very easy for us to understand. Next important aspect is that we are done with alpha blocker. We are left with what is that? Alpha 1 blockers are done. We have alpha 2 antagonist. Alpha 2 antagonist. We have antagonist. We have a chemical that is only called as yohimbine. What is that? Yohimbine. Now this yohimbine, is it FDA approved? It is not a FDA approved drug. Only we have isolated a chemical which is having a property to of alpha 2 antagonist. So do we have to remember? Not important. All right. Now listen to me very carefully. What's that next important? Yeah, we are talking about beta blockers. My dear students, beta blockers are very important concept. So important that without beta blocker you cannot have motion. That's simple as that. So we have beta 1 and beta 2 blockers. Beta 1 and beta 2 blockers. My dear students, beta 1 and beta 2 blockers, they are non-selectively blocking both beta 1 and beta 2 receptor. We have a prototype drug. What do I mean by prototype drug? Any drug. See, prototype is not the potent drug. Our prototype is not some type of drug which will with less dose only large effect. That's potent drug. No. Is it some specialty drug? No. It is any drug which has all the properties of any given group. Means if I am calling it as a beta blocker, means it should be able to block all the beta receptor. Then we are going to call it as a prototype. Okay. What exactly is this prototype drug? Prototype drug is your propranolol. Now, when I'm talking about propranolol, there are two important aspects to this propranolol. What are the two important aspects to this propranolol? These two important aspects are like this. The uses of the propranolol. Another one will be side effects of the propranolol. Uses of the propranolol. My dear students, if it is blocking beta 1 receptor, means we can use them in the treatment of hypertension. We can use them in the treatment of tachycardia. No, all those things are important. No, there is one of the most important thing. It is a drug of choice for a condition called as essential tremor. Essential tremor. What is the drug of choice? Blindly you should mark. Okay. Apart from that, what else we have? What else we have? That is the essential tremor. Apart from the essential tremor, they will ask you one more important aspect. These drugs are used for in a condition that is hyperthyroidism. Now, hyperthyroidism patients will have a tachycardia. Okay. Is it only useful as a tachycardia? No. The patient will also have one important, can develop, not have, can develop one important arrhythmia, that is your atrial fibrillation. Then the patients with hyperthyroidism can also develop one more issue is that the patient will have palpitations. So we can manage it with propranolol. That is point number one. Then second point, that second point is your, my dear students, that second point is this propranolol can prevent little bit of peripheral deiodination. Will they ask you about all these things? All they expect is which beta blocker is used in hyperthyroidism. That's it. Hyperthyroidism. Apart from that, it can be used in something called as performance anxiety. So if I ask you people all of a sudden to give speech in front of some 2000 people, you'll develop a performance anxiety. That time you can use what is that? That will be your program. Okay. Now, once we understood about performance anxiety, then essential tremor, hyperthyroidism, hypertension, I wanted to understand the side effect. The side effects are very interesting. It will cause vasoconstriction because beta 2 stimulation used to cause vasodilation, beta 2 blocking will cause vasoconstriction. So that is why these drugs are contraindicated in a patient with peripheral vascular diseases such as Raynaud's, what is that? Raynaud's syndrome. That is Raynaud's phenomena or Raynaud's syndrome. We don't use them. Even in a patient with having a blood vessels, having a atherosclerosis in the limbs, we don't use this. Here, let's go to the next thing. It will cause bronchoconstriction. So they are contraindicated in the bronchial asthma patient. In the bronchial asthma patients. So for both bronchial asthma, peripheral vascular diseases, we are not going to use one group of drug, that is your propranolol, because it will cause bronchoconstriction and vasoconstriction. Clear. Now let's go to the next important concept. What is that? You need to remember this. Everybody able to follow me? Boring? Or is it getting easier for you people? Yes, we can go for beta to selective. Of course, we can go for beta to selective. Now, sorry, beta 1 selective we can go. Yes, we are having those drugs, but we need to learn about these things, right? That's okay. All right. Hopefully, I'm I'm happy to hear that you people are having this much like flow. Now, let's get to the next concept. What is that? They are your beta 1 beta 1 antagonist. These are very much life taking I mean to say, when you are studying, they are like, oh my god, I cannot remember these drugs. When you are using them, they are life saving drugs also, they'll become very important in our clinical practice. So we can never be a complete doctor without having the idea of beta 1. So beta 1 blockers, my dear students, we have drugs such as S-molol. S-molol. Sir, why are you telling about S-molol? S-molol is a drug. What is this? It is a shortest acting beta blocker. So if it is shortest acting beta blocker, means that will be fastest acting beta blocker. If it is shortest and fastest acting, that means it can be used in hypertensive emergency. So there is a difference between a hypertensive urgency and emergency. Sure, we'll do it. We have hypertensive emergency and urgency. Now, hypertensive emergency is a condition where patient will have a elevated blood pressure. Along with that, the patient would be having end organ damage such as aortic dissection, stroke, retinal hemorrhage. These are the conditions which we can find with hypertensive. Very good. Now, apart from that, we have drugs. What exactly we have? We have drugs such as bidoxolol. Okay. We have drugs such as bidoxolol. We have atenolol. Okay. We have metoprolol. Okay. Apart from these drugs, I want you people to remember some things such as nebivolol. Now, apart from the nebivolol, we have a drug that is timolol. Okay. So how to remember these things? To remember is very easy. Please don't use beta blockers in pregnant female. That too, especially beta 1 antagonists. Beta 1 antagonists are not used. Which adreno blocker are used? I'll tell you people. No, nebivolol and timolol. Beta 1 also they're blocking, and also they're blocking beta 2 blockers also. What I'm trying to tell you, they will block beta 1 receptor and beta 2 receptors, but they're strongly blocking the beta 1 receptor. Weakly they will block the beta 2 receptor. Now, what about these two things? Betoxolol and timolol. These two drugs are used in glaucoma. Especially, what is the first drug we start in a patient with glaucoma? Usually that will be timolol. If he is having asthma, then you go for a beta. Why? Because beta 1 and beta 2. So how to remember? Any drug which has its name starting with from A to M, they will be usually beta 1 absolute selective blockers. Any drug N to Z, they will be your non-selective. That will be your non-selective beta blockers. But I want you to understand, these nebivolol, timolol, majority beta 1 blocker, but they do have beta 2. Let's continue to the next important aspect. When I'm talking about beta 1 blocker, my dear students, what are the uses of the beta 1 blocker? So they're decreasing the heart rate. Okay. Now listen to me, beta 1 receptor, they will decrease the heart rate and they will also decrease the blood pressure. They're used in hypertension management. In the hypertension, the MCQ you are going to get, they will decrease. Remember this word, release. They will decrease the release of the renin. Means what? Will they allow the renin to come out, or it will not allow the renin to come out? It will not allow the renin to come out. That's why we are using them. Let's get to the next use. They can be used in tachyarrhythmias. So tachyarrhythmias. What are the tachyarrhythmias we have? Arrhythmias we have are, you need to understand, that is your atrial flutter, atrial fibrillation, these conditions. Yes, we can use them. Hello. Now let's continue to the next important. Apart from the tachyarrhythmia, where else we can use them? These are used in the chronic heart failure. How exactly we are going to use them in the chronic heart failure? My dear students, chronic heart failure, why we are using them? They can ask you a question. Basically, they increase the duration of diastole. They increase the duration of, if duration of diastole is increased, that means that will increase the filling of the heart. It will allow the better filling of the heart. That is why we are using them. But they are absolutely contraindicated in acute heart failure. If you give them in acute heart failure, yes, that's what I said. If you use them in the acute heart failure, the what exactly happening to patient? If the patient is having acute heart failure, if you use the beta blocker, the patient might die because heart rate will go down. Yes, it is sufficient for solving more than 60 to 70% of the question. Now, apart from that, we can use them in glaucoma, which I already told you people. These are the some most important basics which we should always know before getting into the exam. Right? See, now, once we are done with that, I want you people to understand the next important drugs. There are some drugs, alpha 1 and beta. Alpha 1 and beta 1 blocks. Oh, what are these beta 1 blocks? These are carvedilol, and we have one more, labetalol. That is your labetalol. So what exactly is happening to the carvedilol and labetalol? So labetalol is the drug safe in pregnancy, safe and a drug of choice in pregnancy induced hypertension. In pregnancy induced. Is it only labetalol which can be used? No, there are other drugs. What are the other drugs? That is your alpha methyl dopa, which I told you people. But best drug is labetalol. Then we have one more drug, that's the hydralazine. Hydralazine is a potassium channel. Clear, everybody? All right. Once we understood about this much, now let's continue towards understanding of the next important aspect. What is the next important aspect? That next important thing which we need to know and understand. There are some important and interesting concepts which we always have. We need to have a clear idea. What is that? That first important aspect which we will start with is your cardiovascular system. So why are you starting with cardiovascular system immediately after autonomic nervous system? The reason being, you are already in a flow. Yes, I will give a quick rundown before we go for every break. Now, when we are talking about cardiovascular system, let's start with cardiovascular system. The first important groups of drugs which I want you people to understand is antihypertensive drugs. Antihypertensive drugs. When I'm talking about antihypertension drugs for the treatment of hypertension, now listen to me very carefully. For the treatment of hypertension, most of us have major problem. Now, okay, I'll help you. Okay, now listen to me very carefully. Now, when we are talking about antihypertensive drugs, these antihypertensive drugs, let's start with one of the most important basic mechanism. What happens in your body if BP is decreased? If BP is decreased, what happens? So we had a decrease of BP. We had an event. That event was decrease of the blood pressure was decreased. What's gonna, there'll be what, decrease of the cardiac output. Why? Because BP is less, automatically that means cardiac output is less. That means what exactly is going to? It will activate the sympathetic nervous system. Okay. Now, sympathetic nervous system we understood. Once cardiac output is decreased, that will also decrease the renal blood flow. So there are two problems which occurred. There was a decrease of the renal blood flow and there was a activation of the sympathetic. As soon as renal blood flow was decreased, kidney will release the renin. And sympathetic activation will also release the renin. Why? Because of action of the beta 1 receptors. Renin will lead to the production of production of what is that? That is your angiotensin 1. Why? Because angiotensin 1 is formed from a substance called as angiotensin. Now this angiotensin 1 will get converted into angiotensin 2. Okay, with the help of an enzyme angiotensin. This angiotensin 2 will cause vasoconstriction and also it will stimulate aldosterone production. Okay. Now, sympathetic activation will lead to the activation of alpha 1 receptor. It will activate alpha. Once alpha 1 receptor is activated, they will also cause vasoconstriction. If there is a vasoconstriction, what will happen? Let's see. Now, so far what happened? Cardiac output was decreased. All this story. Now, alpha 1 caused vasoconstriction. My dear students, aldosterone will lead to the retention of the sodium and water. When there is a retention of the sodium and water, that will lead to increase of the BP. Now, as I told you people, angiotensin 2 will cause vasoconstriction. That both effects end up into increasing of the. So, blood volume will increase. Blood volume increases. That will lead to increase. Now, whenever there is a retention of the sodium water, BP increases. Why am I telling you this? The reason behind is that I want you to understand one simple basic rule. What is that? You can use drugs which act on all these systems. BP decrease, sympathetic activation, renal blood flow decrease. Sympathetic activation will increase the renin production. Also, renal blood flow decrease also lead to increase the renin production. Renin will convert angiotensinogen to angiotensin 1. Angiotensin will get converted into angiotensin 2. It will cause vasoconstriction. Same story. Alpha 1 activation, retention of sodium. Both of them will increase. So, we found our problem, we found our path. Now, I want you people to understand, my dear students, when we are talking about antihypertensives, antihypertensives are any group of drugs which will decrease the blood pressure, which will have mechanism somewhere over here. Now, when I'm talking about antihypertensive drug, antihypertensive drugs are first line. We have drugs called as first line. First line antihypertensive drug. I want you people to remember the first group of drugs. They are your thiazide diuretics. Please don't get confused and just don't use the term diuretics because diuretics is a large group of drugs. Diuretics is a large group of drugs and we need to call them as thiazide diuretics because they are the ones which are used as a first line antihypertensive drugs. Then second group, they are your beta blockers. Beta blockers will block the beta 1 receptor. Once they block the beta 1 receptor, they will decrease the renin release. If the renin release is decreased, they will decrease the blood pressure. Remember, renin release. This word is important. These will be inhibited. There was 2 times MCQ. How beta blockers help in the treatment of hypertension like this. They will decrease the renin release. Now, let's continue. Apart from the beta blockers, what else we do? The other things we have are your ACE inhibitors. When I'm talking about ACE inhibitors, how exactly they are going to work? Inhibitors. ACE inhibitors, they will inhibit an enzyme ACE. Now this AC is an enzyme. What exactly will happen? Listen to me very carefully. Once AC is inhibited, it will lead to what? What is that? It will lead to increase of the bradykinin, okay, and it will also lead to decrease of the angiotensin 2 levels. Everybody able to understand? So there is an increase of the bradykinin and decrease of the angiotensin. How exactly it occurs? Listen to me very carefully. This AC is produced by the endothelium of the endothelium of the blood vessels of the lung. Now, this AC will convert angiotensin 1 into angiotensin 2. At the same time, bradykinin breakdown will also done by ACE. When I inhibit ACE, automatically no breakdown of bradykinin, that will lead to increase of bradykinin. Point number 1. Point number 2. There is no conversion of angiotensin 1 to 2, and automatically that will lead to decrease of the angiotensin 2. If angiotensin 2 decreases, there is no vasoconstriction, BP will decrease. Because of increased bradykinin, what will happen? This bradykinin increase will cause a side effect, that is your dry cough. So they'll give you a question like that. A 75-year-old male was taking an antihypertensive drug. After that, he came to the hospital with the complaints of dry cough. Which drug or what is the mechanism of these drugs? They'll give you option. Option A will be AC inhibitor. Option B will be your, what is that? Angiotensin 2 receptor blockers. So you need to understand they are your AC inhibitors. Now, next important aspect. AC inhibitor. What are the drugs? We have drugs. They are your captopril. What is that? Captopril. We have one more drug, enalapril. So these drugs, majority of these drugs are, what is that? Except for one or two, that is one of them is your captopril. Okay. What are these drugs? They are your prodrugs. Thank you. Now, next important aspect. What is that? All the drugs which are ending with pril, they are your AC. Of course. We have one more drug for your satisfaction. Lisinopril. So you need to remember, see, when there is a drug which is having a common ending, just remember the ending. Prodrug means any drug which is inactive outside of the body. When person will take the drug, it will go undergo the metabolism and it will get converted into the active. That's it. Outside body, inactive. Inside body, it will become. We have lisinopril, we have captopril, we have enalapril, we have lisinopril. These are the three drugs. So basically, you need to remember the ending. That will solve all. But one important concept, there can be MCQ for sure. If a patient with C1 esterase deficiency, if the patient is having a C1 esterase deficiency, what will happen? If there is a C1 esterase deficiency, then these people, if they take AC inhibitor, they will develop a problem called as angioedema. So angioedema usually present in which part of your body? In the lips, majorly. So lips will be swollen. A patient was taken an antihypertensive drug. He developed the given condition. He'll give you the swollen lips. If he give you the swollen lips, then what you are going to think about? You're going to think about that is only your C1 esterase deficiency. Right? Let's continue. We understood about angioedema. We understood about C1 esterase deficiency. We understood about pretty much all the importance about the AC inhibitor which are required for your exam. Let's continue the next important. We have a drug called as ARBs. What is that? ARBs. ARBs are nothing but angiotensin. Which angiotensin? Angiotensin 2. This angiotensin 2 will act on its receptor called as angiotensin receptors block. So these drugs, what are these drugs? These are, don't get confused and write. If you miss one word, what is that? R. You are right. Losartan. But I'm telling you people, if you miss one word, that is one letter, that is R, then the meanings might change. That is. We have drugs such as Losar. Okay. We have a drug called as Valsar. Okay. We have drugs such as Telmasartan. That is your Elma-sartan. So all these sartans are your ARBs. They are your ARBs. Now, my dear students, we are done with what? We are done with the 4 groups of first line antihypertensive. Now, next important aspect, what is that? They are your calcium channel blockers. Now, calcium channel blockers can be divided into 2 types. They are your dihydropyridines and non-dihydropyridines. But the drugs which are used acted on the blood vessel. Now, listen to me very carefully. Mechanism of action. They will block L-type calcium channels. L-type calcium channels are located in the smooth muscles. Smooth muscles of what? Smooth muscles of all the body parts. All the smooth muscle will have L-type calcium channel. If I block a L-type calcium channel, then that means that is a calcium channel blocker which is acting on the smooth muscle. What are those? Usually the chemicals are dihydropyridine. When I'm talking about dihydropyridines, now listen to me very carefully. These dihydropyridines, we have drugs such as nifedipine. We have drugs such as nifedipine. Okay. Apart from nifedipine, what else is there? Yes, it will be useful for a quick review, of course. Then, apart from nifedipine, then we have one more thing, that is what is that? Nicardipine. What is that? Nicardipine. Sir, why you are selectively talking about few drugs? There is a reason. The reason is that, see, this calcium channel blocker, there are few drugs, like, that list will have many drugs. We would be using 3 or 4 drugs in the practice. So examiner is focused on those only. That's why. We have one more drug, that is your amlodipine. Now all the dipines are dihydropyridines. If I shorten dihydropyridine, does it sound like dipine? Yes. Verapamil, please don't get confused. Verapamil is not a dihydropyridine. Okay? Continue. Why we are focusing? Nicardipine is a drug of choice for intracranial hypertension. Intracranial hypertension. Okay. Now, nifedipine and amlodipine, they are used for normally treatment of the hypertension, but nicardipine will become the drug of choice for the intracranial. Now, listen to me very carefully. Non-dihydropyridine, that will become as a non-dihydropyridine. Listen to me, all the calcium channel blockers can be used. Uses of the calcium channel blocker, especially dihydropyridines. Dihydropyridines are used in the treatment of hypertension. They are used in the treatment of achalasia cardia. They are also used for anal fissures. Anal fissure, for pain, we use local anesthetics. For anal fissure, to relax the sphincter, we are going to use topical application of your dihydropyridines. Okay. Then next drugs, what we have? Next uses achalasia cardia, anal fissure, agreed. Okay. Now, I want people to understand, anywhere there is a contraction of the smooth muscle, to relax them, we can consider using dihydropyridines. Now, what are the side effects associated with dihydropyridine? They can cause constipation. Why constipation? Because simple. L-type calcium channels present on the intestine also. If they're present on the intestine also, then what is going to happen? L-type calcium channels, when they're blocked, they will lead to decreased motility, causing the constipation. Next, important, they will also cause one more side effect, ankle edema. What is that? Ankle edema. Ankle edema is more likely to be seen with, what is that? More likely to be seen with amlodipine, but it can be seen with other drugs. They can also cause one more problem, that is only called as gingival hyperplasia. Okay. Now these minor effects such as headache and all, it's okay, because they won't become a MCQ at gunpoint, but this becomes a MCQ at gunpoint. That's all right. Let's continue to the next aspect. What is the next aspect we need to understand? The next important aspect which I want you people to understand is that, so we understood so far about the antihypertensive drugs. They are your which line? First line. Now, I'll talk about some important aspects. What is that? I'll tell you people, antihypertensives. If we do the theoretical class, we will end up into problem. So we will do it in a little different manner. Hypertension with BPH. Hypertension with BPH. Hypertension with BPH. Patient is having a elevated blood pressure and benign prostatic hyperplasia. So which is the best antihypertensive? The best antihypertensive. What is that? That is your alpha 1 antagonist. What are those alpha 1 antagonists? Just now I taught you people. What is that? They are your alpha 1 blockers. Alpha 1 blockers. They will, these alpha 1 blockers, when we use them, they will cause relaxation of the blood vessel and urinary bladder sphincter. The next important aspect, there you go, tamsulosin and all those drugs, already told you people. Now, if a patient is having a hypertension with diabetes mellitus, any question, if you get hypertension and diabetes mellitus, what is the best drug? Hypertension with diabetes mellitus. Can anybody tell me hypertension with diabetes mellitus, how can we treat? Remember, the best drugs are ACE inhibitors. ACE inhibitor. Why we are using ACE inhibitor? Because ACE inhibitor decrease proteinuria with your MC. Which antihypertensive decrease proteinuria? Okay. Then, a patient is having a hypertension. We'll talk about diastasis. Hypertension with hypertension with diabetes we are done. Okay, BPH we are done. Hypertension with gout, what is the best? Patient is having gout, along with that the patient is having a hypertension, what will you do? Hypertension with gout, what shall we give him? Better drug is ACE inhibitor, but specifically you need to remember that is your losartan. Okay, then next question. What is that antihypertensive which decrease the release of renin beta block? Now let's talk about the next important. We have something called as potassium channel openers. Potassium channel openers. What are these potassium channel openers? My dear students, potassium channel openers, we have few drugs. What are those drugs? We have a drug called as diazoxide. We have a drug called as hydralazine. Okay. We have one more drug. What is that? What is that? Can anybody tell me? Your favorite drug, everybody should remember, minoxidil. What is that? Minoxidil. Okay. Minoxidil. Now, listen to me very carefully. Diazoxide is the drug of choice for a condition called as insulinoma. Why we are using diazoxide in insulinoma? Because we are using diazoxide in insulinoma, because insulin production requires potassium for depolarization of the beta cells. Hydralazine is safe in pregnancy. See, three drugs, three important points. Hydralazine is safe in pregnancy. Safe in the minoxidil. What is that? Minoxidil. Now, when we are talking about minoxidil is used in topical administration of androgenic alopecia. Why we are using this minoxidil in androgenic alopecia? The reason is very easy for you to understand. What is that? Because this potassium channel opener, along with that, it is having one side effect, that is hypertrichosis. But later this side effect was used as a treatment for androgenic alopecia. If we are using systemic treatment, we are going to use, what is that drug? What is it? Systemically, if we are using, what we are going to use? Systemically, we are going to use finasteride. What is finasteride? Finasteride is a 5-alpha reductase inhibitor. This is the drug of choice for the treatment of BPH. BPH will occur because of some a hormone called as 1,5-dihydroxytestosterone. So for synthesis, we require 5 alpha reductase, which we are going to inhibit by usage of finasteride. First thing is over. The next thing which you need to remember, it can also be used for androgenic antagonists. Clear everyone? So if you know these concepts are related to the hypertension, you can solve all the important. So simple as that, I taught you people all the important concepts to be remembered, and I brushed up your all the things. And I'm going to do one more thing for you people. A MCQ discussion also. Once this rapid revision and all is over, I'll discuss a compiled MCQs. In that way, you people can even get better at solving them once you solve it. Right? All right. Okay. So with this much being said, all the important for the quick revision of antihypertensive. So with this much being said, let's take a small break. So we will take a break of again 15 minutes. Okay, 15 minutes. We will start by 8:50. We'll start by 8:15. See you people again. Let's take a break. All right. Welcome back. Let's start the discussion, right? Shall we? Everybody back? Shall we start? All right, guys. So far we discussed about the important concepts related to antihypertensive drugs. Once we understood about the antihypertensive drugs, I want you people to understand some of the most important drugs which are used in the cardiovascular system. So, shall we start? Okay. So, I hope everybody is back. Okay, let's start. The next important thing I want you people to understand is congestive heart failure. When we are talking about congestive heart failure, you know the causes, you know the congestive heart failure pathogenesis, but I want you people to understand some of the main important aspects. What exactly is that? See, in a rapid revision, whenever we are doing, we need to understand the important topics and we need to revise them. That's the importance. Okay, so congestive heart failure is very easy for you to understand as long as you know the pathogenesis. The pathogenesis, even before going into the pathogenesis, so we have congestive heart failure patient. So when we have a patient with congestive heart failure, the patients with congestive heart failure, the cardiac output will be decreased. Once there is a decrease of cardiac output, because of which there will be sympathetic activation. Along with the sympathetic activation, there will be cardiac output decrease, there will be activation of the RAS system, and the patient, wherever there is a decreased cardiac output, there will be decrease of the venous return. What is that? Venous return. So now RAS activation, sympathetic activation, because of which I want you to understand, my dear students, these patients will end up having edema. Why RAS activation will lead to edema? Simple concept. The simple concept is that RAS will lead to formation of aldosterone. This aldosterone will cause the retention of the sodium and water, which will lead to edema. Now, you know, one problem in the congestive heart failure is edema. All right. Another problem in the congestive heart failure is the patients will also have decreased cardiac output. So there will be cardiac output will be decreased, and this will also become a problem in the patient. So we need to deal with the both conditions, and at the same time we need to increase the cardiac output. So we need to understand the problem, we need to solve the problem. Solving the problem is by increasing the cardiac output. So how can we increase the cardiac output and what can be done? So in the congestive heart failure patients, we use a drug called as digoxin. What is that? Digoxin. When I'm talking about digoxin, this will become a drug of choice in a patient with congestive heart failure. But even before going there, I want you to understand the mechanism of action of digoxin. It will inhibit somebody called as sodium potassium ATPase. Sodium potassium ATPase. So this will become an important factor. How exactly it works? Inhibition of the sodium potassium ATPase, because of which there will be increase of the intracellular sodium. If there is a intracellular sodium increase, exactly where? Of course, inside your cardiomyocyte. That will lead to sodium will get exchanged with calcium. If there is an exchange of sodium and calcium, that will lead to increased contractility. Now, another mechanism of action I want you to remember about the digoxin. It is a vagomimetic. Once it is a vagomimetic, my dear doctors, vagomimetic is a drug. A vagomimetic is any compound which can cause the stimulation of the vagus nerve. Vagus nerve is a parasympathetic. Parasympathetic nerve will decrease the heart rate. Parasympathetic activation will decrease the heart rate. If heart rate is decreased, I told you people during the beta blockers also, heart rate is decreased. If heart rate is decreased, that means diastolic duration is increased. That will lead to increase of the filling. Our patient's problem is what? Pumping capacity is decreased. We need to pump the blood. So for that we need to have a contractility that can be achieved with the help of sodium potassium ATPase inhibition and decrease of the heart rate. So decrease of the heart rate will have a better filling. Both the problems can be solved. All right. Once we understood about this, I want you to understand that digoxin is a so interesting drug, and I want you to understand that digoxin can become toxicity very easily. Why toxicity? Because digoxin is usually not metabolized. Whatever digoxin goes, that digoxin comes out. That's it. Goes inside the body, comes out. So toxicity can be precipitated by hypokalemia. Any drug which will cause hypokalemia, don't combine it with what is the digoxin. Why don't combine? Because I told you people, digoxin will inhibit sodium potassium ATPase exactly by binding to the potassium site. So anything which causes hypokalemia, don't use it with digoxin. Most importantly, you need to understand diuretics. One of the major side effect is your hypokalemia. So if there is a if there is a hypokalemia, patient will have what is that digoxin toxicity very easily. So make sure patient will not develop hypo. Now, what exactly is that? If there is a toxicity of the digoxin, what is the antidote? Now, please don't mark the answer as digibind. The answer is something called as digoxin immune F antibodies. Okay. So let's discuss all the important concepts I want to discuss, because see, after digoxin and after our CVS is done, then the next important things will be like a point based discussion, because you people will have a short time, you need to have a more information. That's all. Okay. So about the time, let's keep going. Digoxin immune F antibodies. What about digoxin immune F antibodies? These immune F antibodies are the ones which are usually called as digibind, but don't call it as digibind. The actual compound name is called as digoxin immune F antibody. Basically, this is only short form called as digibind. Short ways we can call it as digibind, but in your exam, this will not be there. That digibind will not be there. We will have only this thing, that is digoxin immune F. Even I can call it as a market name for the digoxin immune F antibody. That's only digibind. Let's continue. What we need to understand. The next important thing I want you people to understand. What exactly is that. That will be your, my dear students, listen to me very carefully. Once we understood the important aspects related to digoxin, now I want you to understand we have something called as a atrial natriuretic peptide. Atrial natriuretic peptide is increased in a patient with congestive heart failure. Yes, of course. So increased in a congestive heart failure. If ANP is increased in a congestive heart failure patient, means what? It is basically like a natural diuretic produced in your body. Story is over. Now, atrial natriuretic peptide is increased in the congestive heart failure patient. This atrial natriuretic peptide causes loss of sodium. So if it causes a loss of sodium, automatically it will decrease the load on the heart. Okay. Now, this ANP, which can also be referred as BNP. Now, I want you to understand ANP or BNP. We have ANP analog. That is only called as a nisiretide. What is that? Nisiretide. Okay. Means this is decreasing, this is causing the loss of sodium. Because loss of sodium is there, automatically what will happen? Automatically load on the heart will be decreased. We can use nisiretide, which is an analog. Okay. Now, what exactly is that? If I have a ANP, this ANP will be metabolized by metabolic product, metabolized by an enzyme called as NEP. What is NEP? That is only called as neutral endopeptidase. What is that? Neutral endopeptidase. This neutral endopeptidase, if I block this neutral endopeptidase, automatically ANP level will be increased. If ANP level is increased, it will cause loss of sodium and it will cause diuresis, leading to the decreased load upon the heart. So NEP inhibitor, we have a drug called as sacubitril. Okay, so we have a drug that is only called as sacubitril. Okay, apart from that, we can also use other drugs which are used inside your, what is that, inside a congestive heart failure. We can use beta blockers. I already told you people. All right, we can also use AC inhibitors, which will all decrease the load on the, heart. Beta blocker, AC inhibitor, AC inhibitor. Okay, so we have Liseritide, beta blocker, AC inhibitor. Even we can use thiazides. Why thiazides? Thiazides again will help decreasing the load. Okay, now, apart from that, I want you people to focus. See, if you remember all the names of the drugs, that is not going to help. Groups names are very important. Okay, let's continue. Okay. Now, next important aspect. See, these are the things which are asked always in the FMGE exams. That's all. Okay. Now, once you understood about congestive heart failure, I want you people to understand the next important, there your diuretics. So diuretics, why are they coming in a cardiovascular system? Because their major use itself associated with cardiovascular system, but there are also other things. Okay. Now, diuretics are any group of drugs. Which increase the urine out. How will they increase the urine out? By doing something called as natriuresis. So when I'm talking about natriuresis, now listen to me very carefully. We have nephron. Okay. We have, what is that? That is your what is that? That is your loop of Henle, proximal convoluted tubule, followed by that loop of Henle, We have, what is this? That is ascending limb of loop of Henle. This will be your distal convoluted tubule, and we have something called as collecting duct. Now, how and what is the importance of this? My dear students, sodium is reabsorbed inside your, what is that, loop of Henle. That is your sodium, potassium, and also chloride. All three of them will be reabsorbed in the ascending limb of loop, and there will be around 65% of the sodium reabsorption occurs at the level of proximal convoluted tubule. Okay, there will be around 5% of the sodium reabsorption occurs in the distal convoluted tubule. Around 3% occurs in the collecting. Okay, now listen to me very carefully. Whenever I'm talking about diuretics, we have a drugs called as loop diuretics. When I'm talking about loop diuretics, they inhibit somebody called as sodium potassium 2 chloride pump that is located where in the loop of Henle. That is why we call them as a loop diuretics. Okay. Now, what is Bartter syndrome and Gilman syndrome? These are the syndromes which will have a genetic defect. What is that genetic defect in which these symptoms will be having a problem, right? Now, loop that will lead to inhibition. So because of which loss of sodium, if loss of sodium, diuresis occurred, and loss of potassium, loss of chloride. So patient automatically develops side effects such as, that is your hypokalemia, hyponatremia, hypochloremia. These along with that, so patient will develop hypo of all these three. Then next important aspect, what is that? That will be your, they will cause ototoxicity. All right. Now, once we understood about ototoxicity, my dear students, listen to me very carefully. Now, apart from the ototoxicity, please understand these loop diuretics will have some uses. These drugs are used in a condition called as pulmonary edema. And why they're used in the pulmonary edema? Because they're the strongest diuretics which are available. but they're acting in the loop of inlet. There is no perfect diuretic which will completely block what is that sodium reabsorption in the proximal convoluted tubule. The second highest sodium reabsorption, about 25 percentage, will occur inside your what is that location only, your loop of inlet. So pulmonary edema, along with the pulmonary edema, these drugs can also be used in poisoning treatment. Poisoning treatment, especially poisoning or overdose of related to the drugs, etc., where we are going to use forced alkaline diuresis for the acidic drug overdose. That time also we can use loop diuretics. Okay, let's continue into the next important drugs. There are your thiazides. Now, when I'm talking about thiazides, all the diuretics, most important things in the revision, you need to understand one important aspect. What is that? That is where exactly they're working, how exactly. They will inhibit sodium and chloride pump in the distal convoluted tubule. Now, thiazides important aspect. Thiazides will cause some interesting side effects. What are the side effects and what are the uses related to the thiazides? Of course, thiazides will also cause hypo of all the three ions, sodium, potassium, and chloride ion. Along with that, these drugs also useful. These drugs are also having a usefulness, but before going there, they will cause something called as gout, my dear students. Why gout? Because they will increase the reabsorption of the urea. That's all. Now, apart from that, these drugs, when we are talking about thiazide uses, they are used in the treatment of hypertension. These are the blindly. If somebody asks you what is the drug of choice for hypertension, mark it as your what is that? Thiazides. Mark it as your thiazides. That's it. Okay. Now, apart from the thiazide, I want you to understand in the thiazide there are only few MCQs. One of them is your gout. Another one will be used classically in the hypertension. Apart from that, there is one confusing point, that is they are used in the diabetes insipidus. So diabetes insipidus, how exactly they work? There are multiple theories, but none of them is completely proven. So don't try to remember the reason. All you need to do is remember only one thing, that is there are drugs used in diabetes insipidus. Which type of diabetes insipidus? You need to remember this: nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. Apart from the nephrogenic diabetes insipidus, we'll proceed into the next aspect. What is that next important aspect? What is that will be your potassium sparing diuretics. So when I told you people about two types of diuretics, both the type of diuretics which are having one and only problem, they are having a side effect, that is your hypokalemia. Hypokalemia can generate arrhythmia, muscle weakness, right? Now, when we're talking about potassium sparing diuretics, there are two types of potassium sparing diuretics. They are only called as ENaC blockers. ENaC blockers. Okay. Another ones, they are called as aldosterone antagonist. So aldosterone antagonist and ENaC blockers, very easy for you to understand, guys. They will block. See, if I consider this is the collecting duct. This is the collecting duct of a person. In this collecting duct, we have cells. Right, these cells were responsible for, there are two types of cells, intercalated cells and the principal cells. Now these type of cells are here principal cells, they are responsible for the sodium reabsorption. Whenever sodium reabsorption occurs, potassium will be lost, right? So this occurs, sodium reabsorption occurs with the help of ENaC. ENaC blockers are going to block the epithelial sodium channel. Means whenever sodium channels are blocked, sodium is not here. But aldosterone antagonist, they will block aldosterone receptor. If they block aldosterone receptor, then there is no ENaC. ENaC are what? ENaC is a type of protein, epithelial sodium channel, which is responsible for the absorption of sodium. Okay. Now, no ENaC. If there is no ENaC, no sodium reabsorption, that means no loss of potassium. At the same time, if no sodium reabsorption, sodium is lost, that will also cause diuresis. Simple. Now, inert blockers and aldosterone antagonists, we have a drug aldosterone antagonist, that is spironolactone. Now, spironolactone, we have one more drug that is only called as eplerenone. What is that? Eplerenone. Now, what are these two things? This spironolactone will cause a side effect, that is only your gynecomastia. That is only your gynecomastia. Okay. Now, when I'm talking about inert blocker, we have a drug such as called as triamterene, and one more drug that is only called as, can anybody tell me one more drug? That is only called as amyloid. So we have two drugs, amyloid, and there is different drug called as amiodarone is an antiarrhythmic. Okay. Now, if I ask you people, if the patient is having, there are two conditions where you are going to use aldosterone antagonist. One of them is hepatic edema. Hepatic induced edema means any edema caused by the liver disorders. Hepatic induced edema, we are going to use these drugs. Along with that, these are the drug of choice for one more condition called as Conn syndrome. In Conn syndrome, what is the problem? The problem is there is a elevated level of aldosterone. If there is a elevated level of aldosterone, how can we treat? Block the aldosterone receptors. Later, whatever the reason why aldosterone was producing more, we can treat it. Okay. So now listen to me. Now, generally, these are used for all the potassium sparing diuretics. Both of them used for combination with the other diuretics. We are going to use it for the combination with the other diuretics. Now, with this much being said, I want you people to understand the next important aspect. What is that? We have some drugs which are responsible, which are the treatment of angina, anti-anginal drugs. These anti-anginal drugs, see, anti-anginal drugs, they are not complicated. There is simple statement. What is that simple statement? What is angina? Angina is any condition. Where there is increased demand of oxygen and decreased supply of the oxygen. So how to treat? Either increase the supply by causing vasodilation, or decrease the demand by blocking the beta receptors or calcium. That's it. All the drugs we have discussed already. So let's not waste the time on those things. And you have osmotic diuretic. You need to remember one point: osmotic diuretics are absolutely contraindicated in a patient with pulmonary edema. Most important point related to exam. Okay, let's continue to the next important aspects. What is that? That is only your, then we have your carbonic anhydrase inhibitor. They are not used as a diuretics, rather they are used for other purposes such as treatment of glaucoma and mountains. Clear story? Everybody able to follow me? They are your loop diuretics. Furosemides are your loop diuretic. Furosemide, we have taurosemide, and we have bumetanide. All these are. Okay, let's continue. See, I'm going into the concepts which are very important, which have been tested. Drug of choice for motion sickness. Motion sickness we discussed already. What is that motion sickness drug of choice? That is your scopolamine. Morning sickness, that will be your doxylamine in the pregnant female. Doxylamine is an antihistamine with the anticholinergic property. Let's go to the next important concept. What is that next important concept which I want you people to understand? That next important concepts related to central nervous system. Okay, eosinous scopolamine. Central nervous system related concept. So I want you to understand the first group of drugs. What are those first group of drugs? The first group of drugs which you need to understand, your opioids. What exactly these opioids? These are the opioid agonist, which basically stimulate the opioid receptor. Opioid receptors are of how many types? Mu, kappa, delta. Now, opioid agonist. What are the uses of this drug? They are used in the pain management. pain management. Okay, they're used in the pain management of EMI. They're used in the pain management of trauma. They're also used in the pain management related to the cancer related pain. Cancer related pain. Now listen to me, I'll tell you people. So anywhere for the pain management we can use these drugs, opioids. But are they first line? No, they're not the first line always, because based on the condition we can decide. If there is a severe pain, yes, of course. Now, what exactly we need to know about these drugs? Guys, opioids, we have a drug called as morphine. We have a drug called as morphine. Morphine is a prototype opioid. Morphine is a prototype opioid. Morphine is a prototype opioid. My dear, we'll come to the antagonist later. Morphine is a prototype opioid. Okay. Then I want you to understand this morphine is such a type of first point. What is the prototype opioid? Morphine. The next point will be, what is the most potent opioid? Most potent which we are using these days, that is your fentanyl. Fentanyl is what type of opioid? It is a type of synthetic opioid. It is a type of synthetic opioid. It is a type of synthetic opioid. This is the most potent opioid, and prototype opioid will be your, what is that? That will be your morphine. Very good. Now, these are the two most frequently tested concepts. These are the most frequently two tested concepts related to your questions. Now, next important aspect that they will ask you people about opioids. If the patient is having an opioid overdose, opioid overdose, how do you manage? So for the opioid overdose, the management is very easy. That will be your opioid antagonist. But the problem does not lies here. The problem will be, now listen to me, naloxone can be used. But where do we use naloxone? Where do we use naltrexone? Listen to me. We have IV naloxone. IV naloxone. It is a short acting drug. It is a short acting drug, and it is a fast acting. Now, what is this antagonist? Antagonist, we have one more drug. It is available in the tablet form as well. That is your naltrexone. This naltrexone is such a drug. Naltrexone is such a drug which can be used in the management of long-term management of opioid withdrawal. But any patient with opioid overdose, the first thing is IV naloxone. But before going there, examiner will ask you, what are the clinical manifestations of opioid overdose? Opioid overdose people will have, first thing, they will have respiratory suppression. They can develop bradycardia, but not frequently, very rarely. They will develop a pinpoint, they will develop meiosis. Not even pinpoint will be the end state, but pupil will be contracted. Okay. Then the person will also have one more important problem. What is that one more important problem? That one more important problem will be simple yet very important. What is that? That will be your most important thing. That is the patient will be marks. That means wherever he has taken the injection, there can be marks related to it. Right? Now, next important things which you need to understand is your Parkinson drugs. See, Parkinson drugs are very easy for you to understand. Now, Parkinson drugs, let's make it simplified way. Let's consider anti-Parkinson drugs. So when I'm talking about anti-Parkinson drugs, I want you to understand we have a blood-brain barrier. So first thing, all my drugs, see, alcohol dependence, that is never a drug of choice for alcohol dependence treatment, my dear. Okay, yes, it might help a bit, not really. Okay, now these drugs, we have a drug called as levodopa. Basically, the problem was the dopamine cannot cross the blood-brain barrier. So I made a levodopa. Levodopa can cross the blood-brain barrier. If levodopa can cross the blood-brain barrier, if levodopa can cross the blood-brain barrier, levodopa can cross the blood-brain barrier, this levodopa will come here. This levodopa will come here with the help of an enzyme that is only DDC, dopa decarboxylase. Dopa decarboxylase. With the help of dopa decarboxylase, it will get converted into dopa. This dopamine can be metabolized by an enzyme called as COMT and also one more enzyme called as monoamino oxidase B. Monoamino oxidase B. Now, listen to me very carefully. This dopa decarboxylase even present in the periphery. So, what we are going to do? We are going to inhibit this dopa decarboxylase, which is present in the systemic circulation or in the periphery with the help of a drug carbidopa. So now levodopa will not get converted into dopamine, rather it will cross the blood-brain barrier. There it will, what is going to happen? There it will get converted into, what is that? There it will get converted into dopamine. Now next question comes, carbidopa, will it cross the blood-brain barrier? Then dopamine will be metabolized by COMT. COMT can be inhibited with the help of a drug, that is entacapone. Entacapone, and we have one more drug, that is tolcapone. But MAO-B inhibitor, we have drugs such as seligilin, and we have one more drug, that is your rasagiline. What is that? Rasagiline. These two drugs will. Apart from that, dopamine will go and act upon the dopamine receptors. So we can directly stimulate the dopamine receptors with the help of dopamine agonist. The dopamine agonist which we have, that is your bromocriptine. Now, bromocriptine, I want you people to recall this information. Bromocriptine is a latest approved dopaminergic drug in diabetes mellitus. Point number one. Bromocriptine and dopamine receptor agonists, they are very useful. They are very useful in one more condition. What is that condition? That will be your prolactinoma. Apart from that, we will have one more thing. What is that? These drugs can be used in multiple purposes, but most important ones is prolactinoma and antiparkinson. But most importantly, if they ever asked you, prolactin. Now we have bromocriptine. We have one more drug, that is your pamipexole. Wow. We have one more drug, that is your cabergoline. Among all these drugs, dopamine agonist, the long-acting drug is this guy, that is your cabergoline. Long-acting drug is this guy. Who is that? Cabergoline. Clear, everybody? Clear? So when it comes to anti-Parkinson drug, the majority of all of your questions are covered here only with the help of your mechanisms. Apart from that, we have drugs such as amantadine. Amantadine is an antiviral drug which is having an anti-Parkinson property by increasing the availability of the dopamine. All right, let's get to the next important aspect. What is that? See, when you look at this, you should be thinking about this. See, all the anti-Parkinsons revised in one slide. Yeah, you can recall everything. That's what you need. Now, listen to me. So all the aspects which are related, as I said to you people, we will cover up all the important concepts. So these are the most frequently tested concepts which should be discussed in a pharma rapid revision. But I have one more thing for you people. I have one more thing made out for you people. There are some things which you people might be having a difficulty associated with. So there are some fact-oriented questions, and there is some systems, like some system which we need to discuss, that is your antibiotics. What are we going to do for your antibiotics? I want you people to do one simple idea. What is that? All of you, just this we have a Telegram link which is available for your live, which is available for your live, right? So in this Telegram link, just follow the Telegram. Soon I will be sending you people a PDF which contains the questions of the pharmacology. Questions of the pharmacology. In that, I'll be providing you people all the important questions and all the important topics which will be always covered. All right. See, epilepsy is all about remembering the drug of choice. For remembering, you are not requiring the revision. Okay. And rest others, if you done CVS and autonomic nervous system and other parts of the CNS, rest everything is about the fact oriented. We are going to provide the great material for you people. All right. See, I tell you, anti-epileptic drugs. See, this is very simple. I'll do for you people anti-epileptic drugs, but anti-epileptics, listen to me. Now, when I'm talking about anti-epileptics, these are the group of drugs. What we are going to do with this? I want you people to know only one important concept related to anti-epileptics. What is that? If I ever asked you, what is the drug of choice? For what? For this particular condition, you should be able to answer me that. That is your sole purpose of learning your anti-epileptics. So all the seizures. Now I want you people to listen. And please don't bring up your confusion by making the concepts difficult with the trying to learn all the important, all the unnecessary information. Listen to me. All the seizures can have this basic classification. They are your generalized and focal. So generalized, we have one thing called as generalized tonic-clonic seizures. Whenever if the patient is having a generalized tonic-clonic seizures, we are going to use the first drug, that is carbamazepine. So this carbamazepine inhibit neurotransmission by acting upon AMPA and NMDA receptors. Okay, so mechanism of action important? No. Then we have valproate. Along with valproate, we can also use lamivudine. Now, sir, if pregnant female comes to me with the seizure, in pregnancy, the safe drug will be your lamivudine. Then we have next important, that will be your, if the patient is having absent seizure. Now, if the patient is having an absent seizure, all you need to do is age. Why? Because absent seizures are common in children. We'll come to the status epilepticus, right? Absent seizure common in children. So all you need to do, if more than 2 years, or if it is less than 2 years, we'll come to it. Don't worry. Okay, so less than 2 years or more than 2 years. If the age is less than 2 years, you are going to use a drug called as ethosuxamide. More than 2 years, we can use valproate. Done. Then, sir, what about myoclonic seizure? For myoclonic seizure, again you are going to use, what is that? That will be your valproate. Now next question comes to my students. What is that? Sir, what are we going to do in a patient who is having a status epilepticus? When we are talking about status epilepticus, my dear students, listen to me very carefully. This status epilepticus, the first line drug, your lorazepam. What is that? Lorazepam. Okay, you gave lorazepam, but there was no use, or there is no response. If no response, then no response to the lorazepam, then what you are going to do? What you are going to do is, you are going to use phenobarbital. If phenobarbital also does not help, then you can go to the next drug, that will be the phenytoin. Sir, how will we get the question? The question you'll get a patient who was having a seizures, but there was no regaining of the consciousness. If there is no regaining of the consciousness, if that word is mentioned, status epilepticus diagnosis. First drug, lorazepam. He was already given lorazepam, then phenobarbital. He was already given lorazepam, phenobarbital. Then, if at all phenytoin is not there in your question or answer, you can use phosphonate. Phosphonate. Okay, if at all phosphonatoin, then if that also fails, then you are going to go for that is your anesthetics. Okay, why we are going to use anesthetics? To sedate the patient. Sir, what is this levetiracetam? Levetiracetam is different concept. Levetiracetam blocks somebody called as SV2A. This SV2A is a special. What is this special? This is a special molecule which is present on what? Present on the synaptic vesicles. By inhibiting the synaptic vesicles release, so you are going to decrease the seizure. First point. So what is the use? This levetiracetam, now listen to me, it is used for the prophylaxis of seizure. Means what? I want you to understand. If patient had one episode of seizure, you want to prevent him from happening of the second episode, just give him levetiracetam. Just give him levetiracetam, right? So then next question comes to you, sir, which is a safe drug for pregnant female with epilepsy? Epilepsy. The pregnant female with the epilepsy. I'll tell you. Okay. I'll tell you. Don't worry. Pregnant female with epilepsy. Safe drug is your lamotrigine. If you're following some old notes, please don't use that answer. Carbamazepine. No, carbamazepine is not the thing. The drug we have in nowadays, what we are using is lamotrigine. This is the answer. No confusions. Now, ethosuximide. Ethosuximide is a type of calcium channel blocker which acts upon the nerves, which acts upon the central nervous system. It is a calcium channel blocker. It is safe to use. It is safe to use in the absent seizure patient. In the absent seizure patients whose age is less than 2 years, but more than 2 years, we need to use. What is that? That will be your valve. Clear? So, if you need to get the questions, what you need to do? What will you do? For getting the questions, and those questions, there is high likely that same type of things can be repeated. Maybe words will change, but same type of things can be repeated. If I give you 60 question, in that 60 question, if you are getting no, listen to me. If you are in that 60 question, if you are getting 10 to 13 questions from those questions itself, are you happy or sad? First question, first thing I want to ask. And how was the class? How was the class? You people enjoyed? You people learned? All right. All right. Now, one thing. So, I told you about questions, but we'll give you something even better. Something even better. What is that something even better? That something even better is, all you need to do is you need to follow the group, but I'll give you something for the day of exam. Like, on the morning of the exam, you just have to scroll through that in your phone or whatever gadget you have, and you need to get into the exam. Those points will be repeated. Thank you so much. Thank you so much. Right now itself, if you leave now, then it will become very late. That this and all, it will become complicated. How can we easy? How can we easy it right now? By the end of our life, all you need to do is what? Join into the group, right? Okay. Thank you so much. Thank you so much. If you like the class, what you need to do, you need to make sure others also learn from it, not just you. Okay, we are not appearing in like those who are appearing in FMG, what you are not competing, you are qualified. Bye bye, good night. Not good night, not so soon. At least 3 more hours of study is there, right? There is a link for you people, guys. Link is there. After the session, join here for the notes. You will have the link, right? Pinned post will be there. Now you follow that. Yes. I'll give you all the important things with questions in your PDF. Bye bye. Thank you. Take care, guys.